Good morning, everyone, and welcome to the Health and Care Overview and Scrutiny Committee, 20th of July 2026. Do we have any apologies?
Good morning, Chair. I've received apologies from Councillor Brown, Machin, Parton, Woods, Mansfield and Statham.
Thank you. And do we have any declarations of interest? Okay, thank you. And we're going to move on to approve the minutes of the meeting from the 15th of June 2026. Can we take this as a true representation of the meeting? Thank you. And next, I'd like to introduce the Staffordshire and Stoke-on-Trent, the ICB, for their report on the 5-year commissioning plan.
Can you hear me? Okay, thank you. Good morning, everyone. I'm Mish Irvine. I'm the Chief of Staff for the clustered ICB, so Staffordshire and Stoke-on-Trent, and Shropshire, Telford and Wrekin. This morning I've brought to you the 5-year commissioning plan, which links very much to the 10-year plan. We have got some slides for you, and I'm conscious from a work programme perspective we have been through this before, so myself and my colleague brought this to you with a lot of the information offline in a conversation that we had, but obviously that wasn't part of formal scrutiny, so we'd like to have that conversation with you this morning. Zach's going to share the slides for me, so really appreciate that. If we move to the second slide, please, Zach, that would be great. So the background for the 5-year strategic plan, this is very much set within government policy. So we've been working really closely with our populations, with the clinicians, with our provider organisations to create, based on the national requirement in the planning framework, moving from annual cycles of commissioning to a 5-year rolling plan. So we've created a strategic plan that will allow us to have sustainable and long-term impact for our population. We will be able to invest in the long term, so this is something the NHS has struggled to do in the past, so this is going to help us to create transformational programmes which our population will benefit from, but continually benefit from and not have to go through that retendering or recontracting process. This will allow us to have a coherent roadmap for transformation across the system. In order to build the plan, we've obviously looked at the evidence and the data, so the assessment of the population was carried out using the integrated strategic needs assessment data, our population health improvement plan, our clinical strategy, neighbourhood level data and inequalities insight, our long-term ambition for outcomes, inequalities, access, financial sustainability, digital and workforce. So what that means is we've taken a lot of information to help us to understand the needs for the population of Staffordshire. And what we'll be doing is working with our providers to hone that into a neighbourhood level plan so that we're really clear what we need and how we'll deliver health and care at neighbourhood local level for our population. The 5 shifts I've talked to you about before, so the 10-year plan was very clear from the government. We need to move more from caring for people in hospital to moving them to their communities and being able to be cared for closer to home. We'll need to move from analogue working more to taking the appropriate and safe use of digital, sickness to prevention, improving access, both from a GP and primary care perspective, but also in terms of those communities who don't tend to come to us until it's further down the pathway, or perhaps don't come to us at all, so improving access overall, and improving our value and productivity as you would expect and want us to see in terms of taxpayers' money. We'll move to the next slide, thank you. So just to go into a little bit more detail for hospital, community and analogue to digital. From hospital community, what we'll expect to see, so when we allocate the funding to our providers, what we'll expect to see is them working to coordinate and convene the providers that actually offer services in each neighbourhood, to expand neighbourhood multidisciplinary teams, to focus on frailty and long-term condition management, children and young people, and mental health. So those are the areas that we have identified as causing the majority of our population the highest number of issues. And also for us, we need to, from a priority cohort perspective, be really clear that the providers that have the funding, that convene their colleagues and their partners, have to ensure that we have good outcomes and better outcomes for our people linked to these areas. So how will they do that? What we'll want to see is an increase in community urgent response, virtual wards and home-based care. We want to strengthen intermediate care and discharge pathways, move diagnostics and outpatient activity into community hubs, and reduce avoidable admissions and length of stay. So to do that, we'll have neighbourhood teams, so that will include primary care teams, it will include social care teams, it will include the voluntary sector, so along the whole pathway from early years to having a good death. We will expect to see interventions that are appropriate to ensure that people are preventing ill health, but when they have ill health, we are seeing them as soon as we can, but the most appropriate person is seeing them. So it might be that if you're an elderly person, you're lonely, you live at home, actually it's more about being more sociable, it's doing gardening groups, etc. So the voluntary sector being really important in that, to help them to stay well, stay healthy, make good choices, rather than that focus on what we do when people are in hospital and need care. So it's that prevention pathway all the way through. Moving to analog to digital, what we'll expect to see, and you'll have seen this in the news, we will be implementing a shared and inoperable digital record, so shared care records for the NHS. We'll be expanding remote monitoring for frailty, COPD, heart failure and diabetes, improve digital access in primary care, so some GP surgeries do have online triage, messaging and video now, others don't, so trying to make that a universal offer. Using population health management data and analytics to drive our commissioning. So again, what that means is that we will be very carefully linking what we said we wanted to the outcomes that our patients and our population receive. So we'll be much more evidence-based in terms of how we are assessing the work of our providers. And we'll strengthen digital maturity, infrastructure and cybersecurity. As you can imagine, that's going to be a massive priority for us on the basis that this is personal data, personal health data for our population. So we move to the next one, please, Zach. So moving to sickness to prevention, and I've talked a little bit about this, but targeted prevention for CVD, smoking, obesity, diabetes and mental health. So getting involved much earlier, expanding screening, so early detection and proactive case finding, strengthening early years and family support, so working with the local authority on how we work with our young people and children in schools, embedding population health management in all of our pathways, and working with the councils again on housing and employment and environment, so the wider determinants of health, people's jobs, people's choices around the food that they eat, and working really closely with our partners so that that message is given at every possible opportunity, as well as then the secondary prevention, which I've talked about in terms of the screening, testing, etc. Improving access, I know, is really important to yourselves, and we've talked a number of these conversations about access to primary care, so that will be a focus for us, increasing capacity and continuity, reducing elective waits, focusing on long waiters and diagnostics in general, expanding the same-day emergency care and alternatives to the emergency department, improving mental health access, including crisis, and then strengthening the SEND and CYP pathways. Next slide, please, Zach. Thank you. All of this, we're really conscious, is that we have to do it within the NHS pound. We're really conscious of taxpayers' money. We want to ensure that people get the best services in the right place, but also being the most efficient and productive that we can. So we have identified there's a number of areas we need to focus. So reducing unwarranted variation across providers, improving theatre utilisation, which means that when people go for surgery, we need to be much more effective and efficient in the way that we manage that, so we get the majority of cases through at the absolute best productivity and time. We need to think about outpatients productivity. So again, best value in terms of the way that those patients are booked in, when they're seen, how they're seen, etc. And then flow, so the overall flow of the health system, improving the way that our providers work with each other to ensure that people can move through the system. And it's better for them, it's better for their experience, but also it's better for us in terms of value. We need to optimise our workforce skill mix and have shared roles across providers. And I've been here a number of times to talk to you about this stuff before, but the way that we'll commission will now change, where we will expect our providers to have shared roles. We will expect our providers to work over organisational boundaries, to create roles that are different to the traditional NHS social care, and to be very much looking to work with other providers like the voluntary and independent sector. We need to strengthen the ICB's intelligent payer capability, and what that means is it's very much about understanding how we spend our money, understanding how we will analyse and assess whether that money is being spent well, and actually holding then providers to account as a commissioner to say, actually, you haven't given us the value that we expected if that was the case. So being really clear as well about market management, market development, so we can give our services, we can target specific pathways and be really clear about offering our service provision to different providers. So again, there is the best value for money and bang for our buck. Next and last slide, thank you, Zach. So there are a number of delivery enablers, and I won't go through all of this. You'll have had the slides in the papers. But first of all, and I've talked a little bit about this already, about the sustainable and flexible workforce. We want them to work flexibly, we want new roles, we want integrated workforce planning across health and social care, which is something that we haven't been as good at before. It hasn't been in the interests of each organisation to look outside of their organisational boundaries. Now it will be, based on the way we'll commission. We need to have leadership development within the neighbourhood, so again we can be really clear about our workforce and how they're supported to do this work and how they feel safe to take mitigated risks where they need to, so that that's the best thing for the patient. Turning data into actionable insights, so again looking very much from an evidence base, why we are commissioning in a certain way, who we're commissioning from, what outcomes we expect to achieve, and how we then measure their success and what the consequences may or may not be for not achieving that, and widening the scope of our organisations that we commission from so that the population get what they need. Modern and accessible spaces that support community-based care. So we have again talked here a little bit about the development of community hubs and diagnostic centres, co-locating primary community mental health and VCSE services so our population know where to go, and that will be appropriate in some areas, and we'll I'm sure be having conversations about this as we go, being really clear about how we rationalise all of our estate. And then that strong collective delivery across the whole system. So I've talked about this all the way through, partnership working, being really clear about how we use our money. Our place boards will support us to potentially, and depending on the modernisation bill as that goes through, delegate funding appropriately to local places and allow those place boards to manage that spend. And again, very much locally commissioned and locally delivered services with safe and appropriate governance. So I think that was all I was going to say, Chair. I mean, we have got the risks on here as well. Really happy to talk through them as part of the questions. I'm conscious that you probably want to spend some time asking me questions. So if that's okay, I'll stop and I'll let you manage the room in terms of the questions.
Okay, thank you for your presentation. Councillor Greatorex.
Thank you, Chairman. I've got a couple of questions, but if we could start with what I think is a typo, just to sort out my understanding of it. You referred to the risks page, which is our page 23. Under financial pressures and productivity, it refers to the second bullet being inability to left shift funding. So I think there's a verb missing there, but I don't know what left shift funding is anyway. Is it inability to obtain? Is it inability to spend? Is it inability to allocate? There's a verb missing somewhere.
Thanks for noticing and pointing that out. It is a typo. It means the inability to allocate the left shift funding. So the government have given all ICBs an amount of money to support this left shift, so from community to hospital, so hospital to community, sorry. The inability for us to do that is a risk, so for us to allocate that money appropriately and to ensure that providers know what's requested from them and expected from them in a timely way, I think that risk is unlikely to come to pass. We think we have a very clear path for the left shift funding.
Okay, if I can go on to the two questions I had in mind. Also on the risk page, there's reference to ageing estate and limited capacity. And in the body of the text, you've got things like timely access and trying to increase primary care capacity. And that seems to be a counter direction to what's happened in the NHS in the past of reducing primary care. So has there been a change in the way of thinking in terms of now wanting to increase capacity? And the other thing which I was referring to in terms of estates, if you like, is are there parts of the county which are proving to be problematic? If you want to shift from hospital to community, it relies heavily on the community being able to receive the services that you're looking to shift. And that relies heavily on things like council buildings and private care. Do you have that infrastructure available? I know it's down as a risk there, but are there facilities that you'd like to have in different parts of the county?
So we're doing a piece of work internally in relation to neighbourhood centres, and we will be able to bring that back actually to have a conversation once we've taken that through board. It is a risk in terms of ageing estate and limited capacity. However, we are aware of that risk. We're mitigating that risk by carrying out our planning around how we deliver services. So if we do have an issue with that, that will be mitigated. At the moment, we have no significant risks in terms of where we'll deliver our services from.
The follow-up is really, if you're discussing it, who within, for instance, the councils are the touch points, who's talking to whom about any capacity issues?
I would have to take that one back. So I'm really happy to take that question and I'll feed back through Zach in terms of the direct link.
Thank you, Councillor Greatrex. Councillor Norman.
Thank you, Chair. I'm also sticking to the risks there, because normally the risk register, I mean, you have the RAG rating and you have the mitigation arguments there, or options. I presume you have that back at HQ, as it were, even if you're not sharing it with us, but would be nice to see something of that, please. My question is about the VCSEs, the voluntary sector social enterprises. First question is, how important will that be to the success of the plan?
I mean, it would be incredibly important, and we've been working with the VCSE sector for a number of years now. For us, the majority of the work around prevention is in our communities, and this is where the VCSE sector do their work so well. So we work with Support Staffordshire within the Stoke footprint, we work with VAST, and what they do is they link us into those community groups, they link us into the individuals who are leading on charitable work that support people, and it helps us to A, understand what they need from us, but B, help them to understand the services and offer that's available. So they are incredibly important and part of our partnership in terms of the governance. So they do see our commissioning plans, they support us with the engagement. We've got a very clear governance process called, it's the VCSE Alliance group that we use, that I chair, and we work with them really closely on it.
Thank you. If I just ask a bit further on from that, see, I also think they're very important, and I used to work for Age UK, South Staffordshire, later Age UK, Staffordshire, and also I'm a trustee of the Citizens Advice locally. And all those, the welfare benefits and other advice that people get are very important. But as I know from years, different governments, different councils, always trying to get the funding, and it's always very difficult. So if you're relying on the voluntary sector, it's just like an unreliable body to rely on. But I just wanted to be sure that you regarded them as important, and I'll try and get that message out to others as well. I'd say just on the mitigating and so on, is it possible to get a report on that, a more detailed report on
On the risks?
Yeah,
yes. I can
that's all, Chair.
I can get you a briefing on that.
Yeah, thank you.
Okay, thank you, Councillor Norman. Councillor Doherty.
Thank you. So you emphasise shifting care services away from hospitals and into community care. As an example, I recently took a call from a constituent who has mental health issues. He sought help in 2024 and was told then that he would have to wait 60 months for an ADHD assessment. 60 months, that's like almost 6 years waiting. So along with that, and with rising developments across Staffordshire and no infrastructure, taking Burntwood Leisure Centre as an example, 18 years they've been waiting for funding to be approved from the ICB, and still waiting. So my question is, how is this shift going to be achieved realistically, and could we have more detail into how you are going to achieve this, and with LGR coming along as well?
Yeah, thank you for that, and I'm really sorry to hear about what your constituents' experience was. LGR will absolutely have an impact in terms of our place development and the administrative reorganisation that the councils will need to go through. Obviously, is something that will be happening in the background, but we've been doing a lot of work with our partners around place and neighbourhood footprint, and the view is that we don't think there's any reason why that should stop. We've made those partnerships. We're clear who we would like and need to work with to get this stuff done. And for me, yes, you guys will be going through your process. However, we are hopeful that we won't need to really delay the work that we're doing. We're clear on the work's already started. We're clear on our priority cohorts. We're clear on the transformation programs that we need to, and ADHD absolutely sits within mental health, so absolutely aware of, completely understand that there is work to do in this space, and we do need to improve the experience for our residents in that regard. So we've got a number of different work streams, a number of different commissioning intentions, and we'll be clear about the outcomes we expect to see for our residents, and a 60-month delay would not fit within that.
Thank you. It just feels a little bit like you're moving pressure from one area to another when people go to hospital because they can't get an appointment with their GP, or, you know, for whatever reason. It just feels like it's just moving things around and not really solving any issues.
I can understand your perspective on that as a resident. I think GP access has improved massively over the last year, and my colleague Sarah Jeffrey did bring a report that outlined that to this committee. However, I do acknowledge where you're coming from in this regard. What we need to find, though, is a way to support our population to be responsible for their health in terms of prevention, to understand where they can go to at the kind of lower levels of ill health, so that those levels are stopped appropriately. So that's where the work needs to happen in the community. As I've mentioned, there are people who are lonely, who do live not well. They don't live well. They're not making the right choices. And on that basis, they do become ill and they do have to go to the hospital. So we're not suggesting that we're pushing the work that's happening in secondary care back to primary care. What we're suggesting is we would hope to see a reduction in the demand in hospital by focusing on care closer to people's homes. And, you know, I've got children, I live in Staffordshire. I wouldn't want to have to go to the hospital. I'd want to be able to have my services locally in Newcastle where I live and know that I can, A, go to the right person and that I'll get the care I need.
Thank you.
Thank you for your question. Councillor Edgeler.
Thank you very much, Chairman, and good morning, everyone, and thank you for your report. I'm really concerned about, you talk about children and early intervention, and, all right, putting more money into the system. My worry is, have we got the people at the other end that be able to cope with the problems that these children have got? Because you know as well as I do, there's a lack of services with SEND and the children, and children are our future, so we've got to look at them at that early age. And you talk about the elderly and what have you. Please remember, a lot of these elderly don't have computers or anything like that, so please make sure that when you are contacting them, they do understand, you know, it's got to be in paper form really for a lot of people still. And the other thing is, I worry when you talk about voluntary work. Yeah, there's a lot of work being done out there, voluntary, but health really, to do with voluntary, I don't like to hear that actually, to be honest with you. I think health should be by the professionals and that, and not voluntary work. Thank you very much, Chair.
Would you like me to comment, Councillor Edgeler, on... Yes. Yeah.
Yes, please.
So in terms of workforce for CAMS, absolutely understand where you're coming from. So CAMS and young people services. And I think this is where that duplication is something that we need to really address. And I feel really strongly about this in terms of every contact counting with young people. You know, we've got teams that go out into schools to talk to people at really early years to help them understand about making good choices, but also about the wider determinants of health around jobs. And actually this career could be for you, and going into those deprived areas and helping them know that. Then we've got to move through to those people that do actually need more intervention, and trying to think about how our workforce can and will have the capacity to support that. And that's one of the clear outcomes from a provider perspective we'll want to see. So we as commissioners, so that's the ICB's role, we set out what we expect to see delivered by our providers. The providers will then have to deliver that for us, and having a robust workforce to do it, and maybe working with other providers that they hadn't worked with before, for example, to increase their workforce skill mix, may be a way forward for them. I do understand the concern though, and that is something I think it's on the work programme to bring later in the year in terms of a focus on that. Just remind me, sorry, of your other two. I was trying to scribble them down.
It was about the elderly, about the contacting the elderly.
Oh, absolutely. And I think that's why I mentioned appropriate digital, the use of appropriate digital contact, because it won't always be you know, a text message or an email that people get sent. It has to be appropriate, it has to increase access, otherwise there wouldn't be the point of doing that.
You mentioned voluntary work.
Yeah.
That really concerns me.
No, and I understand where you're coming from. It is not the intention from the NHS perspective to, I suppose, ask voluntary organisations to do work that a clinical or kind of registered professional should do. What we're suggesting is that we move back to much more of a community feel. So there will be lots of different individuals. So we've talked about the charity sector, we've talked about Support Staffordshire, we've talked about the interventions that can happen to stop people from becoming ill. There's something about companionship, there's something about popping around to your neighbour to see, actually, are they okay? I can go and get your shopping for you. I do that with my neighbour. When it's icy, he's 87, he's not going to be going out to Asda. So it's that bit that we're trying to support from a voluntary sector perspective.
can I just emphasise to you, and I can't emphasise it enough actually, that when you're looking at children and mental health, that you start looking at that early age, and I mean nursery age. I don't mean when they get 5, 6 and 7. I'm talking about 2 and 3 year olds that are really showing signs of problems, and that is when you should pick it up and deal with it. Thank you.
That's noted, thank you. I'll take that back.
Thank you, Councillor Edgeler. Councillor Wallins.
Thank you, Chair, and good morning to you, everyone. I've just got 2 questions on this particular one. On page 14 to 15 of the report, outlines ambitious moves from hospitals to community care. I was wondering what measurable targets will residents actually see over the next 12 months and that demonstrate that the shift is happening?
Sorry, I'm writing it down this time. Yeah, absolutely. So we've got an outcomes framework that we're in the very final stages of agreeing. This is linked to the left shift money. It's linked to our overall commissioning budget. We have, as commissioners, identified the outcomes and will identify the outcomes that we expect to see. So I'll give you some examples. I haven't got them all, but when we finish the outcomes framework, we're really happy to share that in terms of a briefing. But there will be things like reduced attendance at hospital linked to frailty, for example. We will be looking at the number of avoidable admissions going into the hospital. We will be looking at length of stay. So specific metrics and outcomes that we expect to see that will be going into the contracts that we have with our providers, and then we'll be managing them based on that.
Thank you. And the only other question I've got, if you on page 15.10, one of the first things it mentions is the delivery of the plan requires a sustainable financial approach. With the new Prime Minister coming in, Andy Burnham, have oversight on privatising some sectors of the NHS. What is the risk of this particular area being privatised under a Burnham government?
I mean, you're not going to expect me to make any political statements.
It's okay. You don't have to answer that. Can we not be political, please? Yes.
I was tempted, but no, I won't comment.
Okay, thank you anyways.
Okay, thank you for your questions, Councillor Wallins. Councillor Luca.
Thank you, Chair, and good morning, everybody, and thank you for being here to give this report. I've got a few questions and actually quite concerned on some of them. First of all, if we can't actually get people when they're in one particular place, the hospital, to actually, for our staffing needs, and we're having to rely on agency and bank staff, how are we going to spread this out to the community? I mean, when everything's in one central part, we're already finding it an issue. How are we going to spread that out and make sure that we're not overloading the workforce, which actually then drives my concern that obviously things are going to be looking for cutting corners, and actually if we do start going down that road, it's going to actually affect the service that we're giving to the end user. The other issue that I'm looking at this is sickness to prevention. How, again, in the community, when you have a person, say, with mental health issues that sees it as a stigma, is actually going to engage in the community? I mean, I can't see that happen personally. I mean, and if it ever did, it's gonna take a lot of work just to get that person to admit that they need the help. So I think we need a bit more work on that one. And I mean, as our services are already stretched way beyond what is a realistic workload, how are you going to actually divide that within the new authority systems when they come in to make sure that all these volunteers and third-party agencies that you're going to use are actually fit for purpose. Okay, thank you.
Thank you for that, and really insightful questions. I think the first one around agency and bank and workforce capacity, this is something that the NHS have struggled with and continue to struggle with. Our providers do have specific targets in place to reduce the reliance on agency and bank. So when UH&M, MPFT combined, North Staffs combined come and see you, they can tell you where they are at in terms of their agency and bank usage to assure you that they are not using too much of that. And actually, and I know that having liaised with them, I was a chief people officer and I link closely still with the chief people officers in the organisations. They are actually performing incredibly well in terms of that. What they need is a sustainable workforce. They need to do recruitment and retention. They need to give their workforce a good experience so that they won't leave and so that we don't have the gaps and we don't have to rely. In terms of spreading it to the community and potential for cutting corners, I think, again, I'll just refer back to what I've been saying about the more people that are involved in this work and the more people that understand where we're going and are working in an aligned fashion, then actually we are spreading the responsibility to help people. And I think that links to the second bit around mental health issues and the stigma. You know, I've got a number of family members that have got mental health conditions, and I absolutely know where you're coming from in terms of that stigma. However, where they have sought help, and what we want to try and see is that there are more of a community feel and that there are places that they can go to have that conversation. That doesn't mean they necessarily have to go to their GP and say, I think there's something not quite right, that they might have a conversation in a different forum, whether it be a community group, whether it be going to a charity, whether it be that they're signposted via one of their friends or in a church group, whatever it is, so that they can go, actually, I don't feel right, and therefore I can be signposted into something. And this is where the voluntary community feel, all of that helps us to encourage people to step forward. In terms of the new authority and how we are, you know, just to remind me, because I've written down something, but I don't think I got your last question particularly well. So are you concerned about providers because of the new authority?
Yes, but about how are you going to be able to provide the services?
Well, you know, we've got LGR, and I think I've just said that we will still continue with the place work. The administrative changes need to happen over here, but the place work, the neighbourhood work from an NHS partnership perspective with local authority as well as other providers will continue. And we're so far down that road anyway, I can't see it being an issue for us to continue doing that work. We're clear what we're commissioning as an ICB. We know what we want to see, and we will be working with our providers to ensure that they do deliver that. So the reorganisation perspective, yes, it will have an impact. It will in terms of how we deliver our care, but whether we deliver our care, it won't.
Chair, would I be able to actually have a comeback on that, please? Could I just actually then go on to, obviously, third-party organisations that you're working with? Are these going to have access to data? Because if they're not going to have access to data, how can they actually understand what the end user actually needs in the first place? What is actually going to be the cost? And when it comes to the mental health side, are we going to actually ring-fence protect their funds to make sure that actually the money is there, and the service is fit for purpose, because these are our most vulnerable people?
Mm-hmm. Mental health services is one of our absolute priority areas. If we do decide to contract with an external, as in non-NHS provider, they will have, via the appropriate IG and governance mechanisms, access to data to enable them to understand the patients and the groups that they're serving in the right way.
So would that not actually incur an extra cost when it actually comes to the data protection side and obviously the sharing of information? because your security risk is going to go up.
No, not necessarily. I mean, we've got appropriate governance in place to ensure that. We've got specific policies and processes that we follow when we externally contract. It wouldn't necessarily have a cost. However, the way that we commission means that all of the costs are linked. All of the costs are in that package. So whatever the cost is, it's in there. We're aware of it, the provider's aware of it, and they're aware of the outcomes they need to achieve within that.
Okay, thank you for your questions, Councillor Luca. Councillor Swindlehurst.
Thank you, Chair. Good morning, everyone. Thank you for the presentation, particularly the enabler bit. I quite like that. I also, as part of my role, chair the Staffordshire Moorlands District Council Parish Assembly. So we've got 42 very active town and parishes, and most of those are rural communities. I have to say I have a very positive view on sickness to prevention model. I'm a nurse by background. It's always been the best way of working, and I'm sure it does work. But I'm just interested in how we improve the impact on rural communities to ensure that we've got place-based ways of working with communities. It interests me quite a lot. Thank you.
I mean, in terms of the piece, our population, the public sector equalities duty, we have information about the rural communities. So it's not just about the equalities from an equality diversity perspective. It's actually about deprivation, and it's about rural communities. And we're very conscious and aware of the cohorts of our population that do live, A, in rural, and B, isolated communities. They're across both of our clusters. The neighbourhood model will allow us to support that. So we will have neighbourhood teams, multidisciplinary teams, and ways of working for the moorlands. So this is where neighbourhoods allows us to have very specific care pathways for, I don't know if you want to come in, Steve, but it's very much linked and focused for that neighbourhood. And if it's a rural one, then we're going to have ways of doing it for rural communities.
Chair, sorry, my name's Dr. Stephen Fawcett. I'm one of the ICB clinical directors. I'm here for the urgent care paper, but just on the back of that, I think the most exciting bit about integrated neighbourhood teams and what they can offer rural populations need to be local teams that know their patients, that know the highways and byways, and would be able to help them, support them to stay at their own home, because most rural people would rather stay in their home than go to hospital if they humanly can, if it's safe and appropriate to do so. I think it's quite an exciting time, actually, in terms of a change of emphasis. So I think rural communities might actually gain more than some of the urban ones.
Thank you. That's exactly what I wanted you to say. Thank you.
Okay, thank you very much for your question, Councillor. Councillor Bassett. Oh no, sorry, Mr. Bassett. I keep doing that, don't I? I keep making you a councillor.
Right, well, I'm taking this from a slightly different angle because I work for Health Watch, and we've looked at quite a few of these community services and the interventions from around urgent and emergency care over the last few years. And if you start off with a voluntary sector to begin with, first thing I would say is that a significant proportion of social prescribers in primary care practices in Staffordshire, apart from Tamworth and Burton, are provided, well even in those cases, they're all provided by the voluntary sector, and they're paid for by PCNs out of the ARS rolls. So there are already voluntary sector people, paid people working in primary care, dealing with quite a few of these issues. People who've got time to talk to patients for more than 10 minutes and work through some of their issues, and they are making a significant difference. Furthermore, in the voluntary sector, in mental health, we've seen significant investment from MPFT into voluntary sector mental health services, providing things like crisis cafes, support, social support on the mental health teams, and feedback from patients is that a lot of these organisations take better ways of recovery for drugs and alcohol, for example. All the staff who work in there are people with lived experience, and they are making a significant difference in turning people's lives around because they can work with people knowing what they've been through and showing their experience, and that is very successful. I mean, support, I think Better Ways Recovery has gone in about 4 years to supporting something like 2,000 patients, I think, with addiction issues in alcohol and drugs. I mean, Lichfield in 2 years, they went from nothing to having 500 clients in Lichfield with addiction issues, for example. So that's the voluntary sector. Population health management, we've seen evidence of primary care networks running events where they've scanned their patient populations and identified particular at-risk clients for things like heart disease, and then they've held large events, mass screening of people. Burton, there were 950 went through. Tamworth, there were about 600. Different ways of doing things, but in a day they got to patients, and the patients were saying, well, we could come today, we could get screened, we didn't have to make an appointment with a doctor, it was easy, and you know, we've got advice, risks have been identified, advice about how to go back to your GP, what to say, and so on. So that's another area where I think there's been, there have been developments. The other two things I would say, and I suppose this links to what Dr. Fawcett and co are going to talk about in a minute, but we've looked at all the schemes that have been set up to get people out of hospital quicker, to avoid hospital admissions, etc. And they do work. The issue is there's not enough of them. And I think the calibre of staff you need to work in those services, particularly on the nursing front, you've got to have people who can make decisions. You've got to have senior, experienced nurses leading the process. And where it works, and we've seen the integration of hospital and community working together with the integrated discharge services, and also the links with the ambulance service. I mean, certainly when we did some work with the ambulance service about 18 months ago on 999 stuff, they were saying that they were diverting calls through the integrated system. The problem was there were too many of them, basically. And so I think the foundations are there, and I think everybody wants the same thing, really, but it just needs more of it, and it's how you get there and where you get the staff to do it. So I think there's a lot of positives out there to build on, and you know, I mean, I've been around Staffordshire health services for about 25, 26 years, and there's always been issues at the North Staffs Hospital about delayed discharges and things going back 20 odd years. We've been hearing the same sort of things, but they have made a lot of progress in the last few years, and I think, you know, the foundations are there. It's about trying to build on that, and I say staffing, I think, is going to be a key issue. And then finally, on children's services, I went to a voluntary sector briefing recently, and there was somebody there from the county council who's reviewing all the current early years services across the county, and there are all sorts of government funding streams due to come out to support changes in the way services are done to children. So I think there is some work going on behind the scenes to try and sort that out. I think I better be quiet now.
Was there a question in there?
Well,
More of a statement.
Thank you. Appreciated. Thank you very much.
Okay, thank you. Councillor Doherty.
Thank you. Thank you for that, Mr. Bassett. Whilst I agree with you on some points of that, I don't entirely agree when it comes to pressures on GPs. In Tamworth, as an example, we have immense pressure on our GPs, and that is to do with the fact that Lichfield District Council are throwing up developments all around our borders, and a lot of those people that are now living on those developments are having to go to Birmingham because a lot of our GPs are at capacity. So I'm just wondering if there is funding ring-fenced for new developments such as Arkle Farm, as an example. You know, that's going to have 1,000 houses built on it, and they have no health centre at all. And so a lot of those are having to go further afield to get an appointment. So that's my question.
Thank you for that. So in terms of, and I can't confess to be an expert, but in terms of new developments, my understanding is that there is specific processes that the companies that build those houses need to go through to ensure that there's infrastructure around those buildings. Now, that isn't something that the NHS as an ICB would commission. We're involved in that process, but I'm not sure I can comment on the process specifically for that. I'm aware that there is a process. I'm aware that there is funding. I think they have to actually, as the builders, I think, have to actually do something to ensure that the infrastructure is there. But I'm not an expert, and I can't confess to be one, so I wouldn't be able to comment on it. I'm sorry.
Okay, thank you very much. Councillor Broome.
Thank you very much, Chair. Good morning, everyone, and thanks for your presentation. In the Staffordshire Moorlands, I've one constituent. She has a special education needs child. He's now 7. She's been after respite care for her and her partner. They work ever so hard. She was at the end of her tether 3 weeks ago. She was on the phone. I was on the phone for an hour. This is really concerning for residents. Your strategy for increasing the SEND pathways, does that include funding for respite with a SEND child?
What I'll have to do with that one is take that back. Just to answer your very specific question, I know that the whole SEND pathway is absolutely being looked at in terms of those commissioning intentions, but for funding for respite care, I wouldn't want to give you the inaccurate answer, so I'll take it back, and via Zach, he'll come back to you with a response on that, if that's okay.
Thank you. I'd also like to ask you, how much is, do you have a figure for how much is spent specifically on respite care for the people that look after these children? And the parent tells me that 2 people were sent about a year ago, but they were wholly inadequate, inept. They sat there on their phones for an hour. That no way passes the mother test to let somebody look after your child. But she really, really needs this.
Okay. Again, I'll revert on that one if that's okay, Chair.
Okay, can we make sure that we do keep questions in line with the report? Is that okay? Thank you. Sorry, Councillor Broome. It's okay. Councillor Luca.
Again, just thank you for your honest answers. It's actually nice to actually see, and it's quite refreshing to actually admit that we do have problems within our NHS for the area. But what I actually want to point out is when we look at moving, like it says, from hospital to community, what's going to be the time scales from where we have a first point of contact in the community to actually assessment in a hospital if they need to be referred? What's going to be that time scale, and actually how are we going to carry that out?
I think that, thanks for your question, I think it is potentially condition specific. So hospital to community is more, I guess, not a theoretical statement, but what we're suggesting is that overall what we would like to see is our population being supported nearer to their homes rather than having to attend a hospital, and ideally not needing to attend a hospital at all. Have you got a specific condition or scenario in mind?
No, I haven't got it. It's just all I was interested in is the time scale that it's going to go from community to hospital instead of hospital to community. Because obviously if somebody is, say, on the point of mental health where they're close to suicide, we don't want them waiting 4 weeks for an appointment, which actually has happened before.
So the timescales do vary based on condition. We've got some really specific referral to treatment targets that we do need our providers to deliver. So it would depend on the condition, but we have got rigid outcomes in terms of that. Some of them are nationally set, and some of them will be within our outcomes framework that I was referring to with Councillor Wallens there. So we will be very conscious of and aware of, and we currently are, to be fair, with this stuff, that the delay between where someone presents asking for a referral and requires one to when they get their first appointment.
Okay, it's just, I'll use myself as an example. I'm a type 2 diabetic, and I was given a referral for urgent treatment because my sugar count was 91. I'm still waiting for that letter. I've been a diabetic for about 4 years now. So obviously, the point I'm trying to get at is, if we're going to take it where, again, coming back to where we have everything at the minute in one place, how are we going to make sure that the time scales are going to be actually fit for purpose, to make sure that we are actually making sure that at the point of need, the end user is actually getting that help?
Do you want to go?
So thank you for sharing that, and I'm sorry you've had to wait so long to get an assessment. I think that, yeah, and in a way, it illustrates the challenge that the NHS has in terms of getting those pathways right. And I think diabetes is a good example, because actually that is an area where you can increase the community capability and capacity by working a different way. If we look to other systems, Leicester, Rutland, for example, organise their pathways in a different way. And I think as we move into this hospital to community focus, we will be able to improve that capacity. We will have more consultant outreach, we will have the greater ability and greater productivity, because that's ultimately what we need. We need to be able to get people through these pathways in a more timely way. So again, apologies that you've had to wait so long, but you're exactly the sort of patient that we want to help.
Okay, thank you.
Okay, thank you very much, Councillors, for your questions. Councillor Norman.
Thanks, Chair. Just be clear what Councillor Doherty said earlier on, which was regarding patients living in east of Tamworth and the new estates there, having to go, if I understood it correctly, to Birmingham to a GP. Is that correct? Did I hear correctly?
Councillor Norman, is this relevant to the report?
Sorry?
Is this relevant to the report?
There was a statement made. I just want to be clear if I heard it correctly. The patients in the east of Tamworth on the new estates were having to go to Birmingham. If that's what she said, I just want to be clear about that, please. That's all.
Okay, thank you. Is there
Yes, you heard correctly.
In that case, can I just say that you can't choose a GP in Birmingham or Coventry or
Councillor
Warwick,
Norman,
can
can
you?
we keep questions relevant to the report, please? Is that okay?
We've allowed that question about housing, and I can explain what the housing rules are regarding GPs. So that I just want to be clear when somebody makes a statement that doesn't get out as actual fact. I was trying to get the.
We're keeping it to. Thank you, Councillor Norman. Okay, so does any other councillors have any other questions? Okay, thank you. So I've actually got some questions myself to ask, if that's okay. Okay, thank you very much. Can we make sure that any disturbances are kept to a minimum? Thank you. So obviously you've identified a number of services that are going to expand into the community. You have explained some of those services. So exactly what services, I mean, I know you went through some, but exactly what services are going to expand away from the acute hospitals, at what scale, if that's a possible answer you can give, and how many patients are expected to receive their care differently as a result?
So it is difficult to answer that question to the level of detail that I think, and quite understandably, you're asking me. In terms of the services, they will be linked to those priority areas. So children and young people, mental health services, frailty, we've got to then, and prevention. What we also have to do is to improve the UEC pathway as well. So there'll be, within each neighbourhood, I mean, some of the services will be delivered at place level, so across Staffordshire. So when we're looking at, for example, UEC services and frailty, there might be things that we say, actually, we're going to put these integrated multidisciplinary teams into place, and that will be implemented for all of our population in a very similar way, but at neighbourhood level. There will be some services that we will want to see at neighbourhood level that's specific, so it might be for the rural communities, they have a very specific service. Our outcomes framework will outline what we expect to see. The providers will be the individual organisations that have to convene to work together to deliver those services. So we have, in January, we have another scrutiny conversation with yourselves around neighbourhood delivery, and I'd ask you to ask me those questions there if you can, because we will have a much clearer idea based on the left shift money having been allocated. We'll have a much clearer idea of actually what those services will look like, but they will be within the brackets of and the umbrella of the overall services that I referred to with you.
Okay, thank you. My Councillor Luca. I'll let Councillor Luca come in before I ask my follow-up.
Okay, sorry, just obviously from what you asked, Chair, and from the response, a question came to mind. Under the LGR split, the north and south, obviously the south is going to have the greater population than the north. How as obviously a provider, are we going to actually split the funding to make sure that it's actually realistic for that area's population?
So in terms of the way that we manage the money from a contracting perspective, it is based on population, it's based on the priority cohort. So it's not, so I talked to you at the start in terms of the information that we use. We look at the population health needs, we look at inequalities, we look at actually the activity that comes through, and we would also look at the number of heads, the number of people that live there. So we as commissioners will allocate via our Chief Finance Officer the appropriate amount of money for both the north and the south based on LGR. How that money is spent and how actually those services are delivered will be probably based on pathway, it will be based on cohorts, and the providers will have to deliver that work. So it is a very complicated system. There's a number of different contracts. Some of it's primary care, some of it's linked to community, some of it's linked to UEC, etc. So I won't go into a massive amount of detail on it, but it will be done appropriately and evidence-based.
Thank you for your answer, but I still have the concern that this potentially could actually mean that one area is not as well looked after, and not because of anything you're doing, simply because of the financial struggles that the two new authorities would put on the system.
And I'm sure I can't comment on, I suppose, that bit of it. From an ICB perspective, we have our funding that's allocated to us, and we will work in the way I described to ensure that everyone has equitable access and equity where they require it.
Okay, that's pretty much what I was going to ask about the level of investment and how much has actually been identified or secured, but obviously Councillor Lucas sort of got in there. No problem. I was just wanted to assure as well, if you could assure the committee that sufficient community capacity and operational efficiency can be demonstrated to be safe before you actually start to shift away from the hospitals, to make sure that capacity is there, operational and working before it's actually taken away from hospitals. Can you assure this committee that nothing will be taken away from the hospitals before that you know for sure that that is being put in place?
Yeah, and I absolutely, because in terms of the way that we manage our contracts, if there is significant service change, so if something is stopped specifically at the hospital, there is a significant service change. There is a whole consultation process that we would have to undertake. What we're trying to do, actually, with this strategic plan, yes, there might be some service change and service cessation. If we look from an evidence-based perspective and think, no, actually, the patients aren't getting the outcomes that we'll require from that, we would go through the appropriate process. However, what we're trying to do is to build community capacity. So we're offering, as Dr. Fawcett referred to, we're offering new services. We are asking and expecting our providers to work differently so that our populations have more, not less. So it's a different way of doing things closer to people's homes.
Okay, thank you very much. I also wanted to ask, hold on, I think these have already been answered. Let me just...
Okay, no worries.
You have a question. You ask your question and then I'll carry on with my questions. Yes, okay, Councillor Broom.
Thank you very much, Chair. We mentioned about cost of programmes. Do you have any figures? I mean, how is staffing at the moment? Have you got many vacancies? And do you have quite a high turnover of staff?
As a commissioner, we don't have... What I can't do is speak on behalf of the NHS trusts. So, and the NHS is generally the groups of organisations that we do tend to refer to. I'm sure that there are many, many other organisations as well. From a vacancy perspective, from my current knowledge, the turnover is around about 10%, which is good for NHS trusts. That's normal if you compare it to social care, which is around 22 to 27%. It is actually really positive. Vacancy levels do vary. At the moment, they're relatively static and stable in the NHS trust, especially from a clinical perspective. But I would encourage you when UH&M and MPFT and North Staffs Combined come and see you to ask those questions directly of the officers from the organisations.
Okay, thank you very much. I have identified some more questions. So you said that you're going to measure the changes, okay? So will you measure that they have genuinely improved outcomes rather than just changed where the care is delivered? Also, what outcome measures will be used and how will they be reported to us?
So absolutely the answer is yes to your first question. We will genuinely be measuring that outcomes have improved, both patient experience, so that's one of the outcomes that we'll be looking at, which is a relatively new thing. We will be measuring specific outcomes linked to particular conditions, and as I said, Councillor Wallace asked a similar question in terms of that, so we will, sorry, Wallens, I realised straight away I'd said it wrong, apologies. We'll be measuring things like admissions rates, number of patients that are coming in with specific frailty conditions. We'll be looking at the referral to treatment times. There'll be more than that. And our outcomes framework, as I said, is at the final stages of being confirmed, because it's going to be quite detailed, because it is linked to so many different conditions and pathways. What I can do is to provide a briefing to this committee in relation to the outcomes framework, and if you would like us to go through that in terms of our performance on it when we come to see you in January, I think that would be appropriate as well.
That was what I was aiming towards, actually.
Yeah.
So, and that's very, very good, thank you. Would you be able to, if possible, so it's obviously we've had a lot of people talking about rural communities, and then you've got more urban communities. How are you going to ensure that the benefits of this plan are going to be delivered equally, or at least so that different communities can access the correct provision for them, and making sure that improvements are not being concentrated in areas that can already access these quite freely?
And that is the beauty of neighbourhood working. It's the beauty of using a multi-source evidence base to design what we understand to be the priority cohorts in each area. So we have used multi-source evidence to help us understand the needs for each neighbourhood. We have not just used the NHS data, our providers are also working, and I think Dave mentioned that PCNs are speaking to their populations actually about the requirements for their areas. So on that basis, we will find that there will be equity. So rather than just equality the same for everyone, there will be equity in terms of if there are areas of higher need that need different care pathways, different models in order to increase access, for example, that we would expect the providers to know that and to deliver it, and we'll be measuring them on that basis.
Thank you very much. And is there any chance that future reports could provide, and maybe being a bit cheeky on this one, to provide district and borough level performance so that we can actually identify, I know that that may be a little bit complex, but I think it would be quite important that each of the areas could be monitored individually to make sure that each borough and each district is receiving the care that they are obviously, it's being proposed.
Let me take that back, Chair, and see if we can do that.
Councillor Luca.
Just because we refer in the background to the 10-year plan, I can remember that in the report when we were talking about staffing, it said that 1,100 positions would be affected. And that's what it actually stated. So obviously, because we're actually moving this away from the hospitals to community, how is that going to be implemented to make sure that we have enough frontline staff? And is this actually going to be a case of, when we do move it over, when it comes to the backroom staff, what's going to be the percentage of backroom staff needed to actually support the front door staff?
Are you referring to the UH&M operational plan from 25 to 26? Because that's where the 1,100
yes, I am.
was referred to.
But it's just I bring it up because it's referred to in the background for the report today.
Yeah, absolutely. And I think, again, I would encourage you to have the specific detailed conversation with UH&M colleagues as they attend. I do know, however, that number of workforce weren't reduced at UH&M. They have managed to find a number of different ways to ensure that the actual workforce headcount hasn't been reduced to that level by any stretch. So that's really positive. In terms of the backroom staff, so the corporate colleagues supporting this, I wouldn't be able to comment from a provider perspective on that. It might be a question for you to ask the hospital when they come.
Thank you. Is there any more questions? Okay, so I think what we've gathered from this meeting, there are obviously a lot of concerns. However, you have said that you would come forward with a report. So, I would like to ask the ICB if you could return with the delivery dashboard for each of the 5 strategic shifts, showing, for my own sort of curiosity, current baseline performance, if that's okay, so we can check that against any future reports or any future meetings. The outcome that you're trying to achieve, I think that's more of a, for each of the concerns that have been brought forward. If you could bring forward sort of annual milestones and targets, so that anything you think you're going to achieve this by, you know, October, maybe January next year, what it is that you want to achieve and wherefore. And I think you're coming close to that, aren't you? You said earlier. So if you could bring that forward to us. The sort of the key risks that you genuinely think might happen. I mean, there may be some that I know you identified some in the report, but any that might come up at a later date, if you can bring those forward. If you identify any key risks in regards to delivering these services and any actions being taken where delivery is off track. So what is it that, where you haven't been able to deliver a service or take something from the acute sector, Why is it that that didn't happen? If that could come forward to us, that'd be greatly appreciated. Thank you. Thank you very much.
No problem. Thank you.
Thank you. Okay, next on the agenda then is the winter lessons learnt, and that is the Staffordshire Stoke-on-Trent ICB, and it's about the winter plan. Thank you very much. If you'd like to introduce yourselves.
Good morning. My name is Gareth Wright. I'm the Director of System Improvement Coordination, Emergency Preparedness and Response and Resilience, quite a mouthful at the ICB. In plain speak, I'm Director of Ops, is what you probably recognise for that. I've been in post for the cluster ICB of Shropshire and Staffordshire since the 1st of July, but prior to that, for 2 years, I was doing the equivalent role for the Shropshire ICB. So I led the winter response in Shropshire last year and looking forward to bringing that approach to both counties this year going forward. I will have director level responsibility for the winter plan, for developing it and then the implementation as we go through. With me today I've got Dr. Steve Fawcett to my right, who's already introduced himself. He's our Clinical Director for Operational Matters, in plain speak at the ICB. And to my left is Jack Butler, who is my deputy, who will co-design the winter plan with me, but will have a really important role in the implementation of that during the onset of winter. So, if it's okay, Chair, what I propose to do is let Steve just give an overview of reflection of how winter felt for us, and then Jack has got a presentation ready to give you some more detail, and then, of course, be very happy to take the committee's questions afterwards. Just before I hand over to Steve, though, this is a really timely opportunity for us as we start to develop our winter plan to receive the committee's thoughts and reflections, because that can directly influence the way that we shape our plan as we're putting pen to paper, finger to keyboard at this current time. So if that's okay, thank you for the nod. I'll hand to Steve to just give some headline reflections.
Thank you. Thanks, Gareth. So I'm a clinician, and I'm still a practicing clinician. So we know that every winter is late autumn and winter is a time when we see very much increased activity, and the winter plan recognises that. I've been involved in, I can't remember the number of winter plans I've been involved with, but it's in double figures. And what we've done in Staffordshire and Stoke-on-Trent, and Gareth said we'll do across the cluster, is we've tried to learn from those, trying to learn from those plans every year, because it's iterative. Every plan every year of experience allows us to gain insight into what works, what doesn't work, what we need to do more of. But at the heart of it, and very much in the forefront of our minds, is making sure that patients are ensuring their safety, making sure that we're looking after our staff, and making sure that we've got ways of getting patients home as quickly as we can. The slides will cover off some of the performance issues that we've had over the winter, as well as some other reflections. But what I would say to you is that we will learn again, we will carry the learning again from this 25-26 into the 26-27 plans. And as Gareth says, it's very timely, because we are although the sun is shining and it feels very hot outside, we are deep in the realms of trying to develop our plans for next year. So it would be useful to get your insights that you'll receive from your constituents, and help us shape the plans for the following year. And I'll hand across to Jack.
Thanks, Steve. Morning, everybody. So what we've done is obviously shared the report with yourselves in advance. We've just pulled together a few slides that just draw out some of the key detail. We wanted to go into a little bit more information with you all. Obviously, we can arrange for, I don't think these made it over to yourselves on time, so we can arrange for these to be shared if need to be afterwards, just to go through. So obviously we're looking back at our winter 25-26. On the 6th of May, we came together as an ICB and with all of our partners across the system to undertake our Winter Lessons Learned event. This was our 3rd year of undertaking the review in this way, and what I will say is this is probably our best attended session that we had. We had representation from all of our NHS partners, but also some of our more sort of smaller independent partners, primary care colleagues, etc., around the table. We had a really clear focus around this about making sure that we use our ICB Leadership Compact, which basically underpins how we work collaboratively to make sure we get the best out of the session, make sure that we can draw in all of the views through there. We had a couple of key focus areas, so making sure that what we'd done in 24-25 had actually made its way into our 25-26 plans, and that those reflections had been brought through. We wanted to make sure that we got quality and patient level focus through there. Obviously, as we're in the depths of winter, obviously we're dealing with patients on a daily basis, but we didn't want this just to be around the numbers and the percentages and the performance. So we started this session off with a really good patient story to understand not just where things went well, but where we still had our challenges that we needed to address. We went through an overview of our performance, which we'll go through, but what we wanted to do then was have a holistic view and feedback across the whole system so that we made sure we got the reflections of what went well, what didn't go so well, but also what do we need to do as we move forward into our 26-27 planning. And we had a real focus around that in some of our breakout sessions. In terms of our performance, just bringing it back for a moment around the performance, what I think we can say is 25-26 was not ideal, but it was much improved on our 24-25 performance that we went through. So what we've included in the pack, and we've got a little bit of detail here, is around some of those performance and the numbers, listening to Mish and colleagues talking before, around, so our category 2 response times around our ambulances, have improved. Still some way off the target, but we were around 4.5 minutes improved on where we were in 24-25. Ambulance handovers, we couldn't talk about our winter pressures without talking about our ambulance handover challenges that we face as a system. Compliance with the 45 minutes standard across Staffordshire and Stoke remains a challenge for us. During winter, we saw that performance drop to around 45 to 55%. That's improved. Obviously, we've come through the summer months. We have our good days, we have our bad days, but that is still a real focus area and will be a focus of our plan as we go into 26-27. What we should just say is County Hospital in Stafford and Queen's Hospital in Burton achieve a much higher compliance against our ambulance handover target, so we have a lot less delays at those two sites than we do if we look at the Royal Stoke site. Attendances, as we would expect, increased as we go through October into November, was our peak, but our emergency admissions followed along with the attendance growth, but they then stayed high even when the attendances started to reduce. So we talk about acuity in urgent and emergency care services, so how unwell patients are. What we've seen is a rising in acuity over the last couple of years, and that sort of works with that even though the patient attendances are reducing, those patients still are very unwell as we go through. Our performance against the 4-hour target, so performed really strong in terms of our type 3 sites. So there are minor injury centres, our walk-in centres, so Haywood Hospital for colleagues, Samuel Johnson in Lichfield, around 97 to 99% as we go through. Our 4-hour performance, our type 1, so our major A&E sites over at Royal Stoke, for example, was around 35 to 45% as it goes through. However, what we did see is a 4.6% improvement over the course of the winter period. 12-hour performance, so this is a metric where we really started to focus over the last 2 to 3 years. Historically, focus has been around 4 hours, but the pressure and where we have our bigger harm to patients is those 12-hour delays, the patients that are waiting in emergency departments to be admitted or to be seen in a different sort of section of the hospital. That came through at 9.64%, so some marginal improvements on the previous year, but it's still, that's probably one of our better targets that we can work towards focusing on this year. And then our bed occupancy, so how busy was the bed base, how full was the bed base. realistically between 95 and 98% during UH&M during the course of the winter. But what we wanted to really draw out, and we'll discuss it a little bit more, is our Home for Christmas campaign, working with our integrated discharge hub, where we actually saw on the 24th of December our occupancy levels down in the 83-84%, which when we set that target, we all sat there and being honest, was like, this is going to be a real stretch and a real push to get to 85%, and we actually exceeded that to get ourselves down to between 83 and 84%. Steve, if I can pass to you for a second.
Sorry, Chair. Yeah, so the winter review meeting, it was, as Jack said, it was very well attended. We have quite a strong clinical presence, which I think helped the review about harm and quality, because that's, as a clinician, that's one of my key interests. And the slide describes the key areas. I don't think any of them will be a surprise to you in terms of what the clinicians and the quality teams felt about things that we needed to concentrate on for the 26-27 plan. Discharge is clearly a major theme. I think somebody mentioned, I think it was a Health Watch colleague mentioned about delayed discharges, but actually our discharge services are actually at Royal Stoke site are really very good. They're held as exemplars now. But nevertheless, there are still challenges along the pathway which aren't great for experience. And in fact, Jack mentioned the patient story that we had at the beginning of the winter review, and that brought out some of the challenges around discharge. There's a sustained pressure across patient pathways. Jack's mentioned about the 12-hour metric and the ambulance handovers, but we also need to just be mindful of the fact that we've got pressures out along the whole pathway, particularly in the community, in the pre-hospital space, and that's an area that I think will need focus in the 26-27 plan. We recognise that when you have patients in non-designated areas for emergency care, and when you have very crowded departments, that can be a big stress for clinical colleagues. It's not only is it busy, but these patients, as Jack has said, are often quite unwell. So we need to be, the planning needs to be trying to reduce those pressures on staff if we can, because ultimately, if the pressures become too much, people will go off sick or will struggle to cope, and we see that every year in terms of winter. So in terms of from the quality side of the winter planning, those are the four areas that we particularly want to run as themes throughout the planning and test ourselves about what we're doing to mitigate those.
Thanks, Steve. Just in terms of how we undertook our feedback then, as we've spoken about, we wanted to have a real focus around what worked well, what could be improved, and what recommendations would we take into 26-27. As we said, it was a well-attended event, so we wanted to make sure that we could work our way through all of our partners, and we had a real focus around our three key pathways. Now, there's lots of pathways within sort of the NHS for patients, but bringing it down to three key UEC pathways for us was, what is our alternative pathway? So what happens before they come to the hospital, the emergency department? What happens once they're within the acute hospital or the community hospital? And then what happens in discharge and post-hospital? And they're the sort of key themes that we worked through. We've brought this together. It's sort of some really key positives that went through, but also some of our learning. So in our pre-hospital space, taking on board what our Health Watch colleague did before, we've invested a lot over the last 12, 18 months with our ambulance service colleagues and building what we call our ICC, so our Integrated Care Coordination Centre. So this is a specific single point of access that works with health and social care professionals that are out in the community to manage those escalating patients, to try and come up with alternatives to admission, working with those community teams. And as we go back into the neighbourhood health area, will be a sort of route that works closely with people. We increased our capacity of our urgent community response, so UCR services, so more locally known as our CRIS team. So that's our 2-hour rapid response, advanced practitioners that can visit a patient in their own home within 2 hours to support admission avoidance. And then we're working with our primary care colleagues to focus around how we mobilise some additional primary care hubs, additional primary care capacity, so that we can go through there. But we know from our conversations that we've still got some way to go. So the ICC's done really well with things. So if we look back around 18 months ago, they were doing about 800 referrals a month. They're now averaging around 4,500 referrals per month. and diverting around 55% of those patients on average away from acute portals and keeping those in the community. And we actually have, we may not have the only now, but we actually had the first 24/7 integrated care coordination centre function available to our ambulance service colleagues. We need to look more around what we do with our work with care homes, and there's a specific programme of work around care homes that's now launched across Staffordshire and Stoke-on-Trent, and how we can use our virtual wards. In terms of our frailty, we've done really well in 24-25 with a frailty same-day emergency care unit at the County Hospital in Stafford. That's now been expanded during 25-26 to have that similar service available at Royal Stoke, and that's having some real positive impacts on that elderly population that do need to attend hospital. What we did in 25-26 as well is we increased our physical capacity. So in previous years, we'd looked at improvements in flow, looked at different things that we could do, but we didn't have the capacity to put physical beds in. Whereas in 25-26, we also increased some physical bed capacity through using space differently. We do need to do some more work, though, with our frontline teams so that they better understand the operational pressures across the whole health economy and across the whole system. We see the pressures when we have the challenges. They're visible to ourselves, they're visible to the public. It's usually ambulances sat outside the hospital waiting to get in. What we need to make sure is the level of pressure that our colleagues working in an emergency department, for example, is understood the whole way through the patient journey, because a very small decision right at a discharge element could actually release the pressure within the emergency department much earlier. And if that's just discharging that one patient 2 to 3 hours early, that will improve that flow piece through. So we need to do some more work around there. We also need to do some more work around ensuring we don't impact on our elective capacity. So we went into winter with an intention of not impacting on our elective capacity in our elective programme. Unfortunately, that had to be impacted on. We had to bring down some of the elective ward space to support urgent and emergency care pressures. And there's various different reasons around that, but we know this year that that needs to have a little bit more focus to make sure we do not impact, or if we do impact, we impact on a more planned way rather than having to make decisions at short notice. Discharge, so we've talked about our hospital home for campaign. We did a lot of work around our discharge facilitators, so increasing our 7-day coverage. And what we actually found is by implementing that 7-day coverage, we took away some of our bottlenecks and challenges that we historically saw on a Monday and a Tuesday, so we improved that flow across the 7-day period. It made the journey better for our patients on the Monday, Tuesday as well as we went through. We also did some new work around our overnight wrap scheme, so working with both local authorities to make sure that we can just step up that little bit of provision for the cohort of patients that don't need to go into a pathway to community hospital bed but need a little bit more support than we can work through there. So that worked well as we go through. You'll have seen in the paper we talked about our pillared approach for how we undertook our winter planning. We actually think that worked really well last year. It brought in all of our partners across the health economy that historically would have supported, but maybe were a little bit more on the peripheries, and actually brought them all into the core conversations and discussions with us. Our System Coordination Centre is our 7-day ops function, basically, and held the ring on everything as we go through the winter. We also undertook, working with voluntary sector colleagues, primary care colleagues, some winter-ready patient events. So each primary care network hosted one of these events, and these were in the communities for the patients, where they were able to come in and understand what does winter mean and how can they help themselves, how can the NHS help them. So doing things like NHS app registrations, being able to provide leaflet support, helping with vaccinations, really being able to focus on those key areas. We do need to do some work around our learning around finances and agreeing any financial programs that we need earlier so that we can help that mobilisation period. And also as we move into our cluster arrangements, how we simplify our governance arrangements as we move through. And some of that's been helped this year by the changes in the NHS's winter response, so that all organisations and each individual board will now need to provide its own winter plan and own assurance statements around those as we go forward. If I just very briefly then go into our sort of 26-27 priorities, giving that future look. We've agreed some key planning priorities for us as we move forward. A colleague, I think it was our Health Watch colleague, said earlier on around what do we need to do and what do we do differently. One of our key principles that we've all agreed as a health economy this year is, rather than doing lots of new different things, We just need to focus on what we do already and do it better. And that's a focus that we took particularly in our discharge space last year. And really, we didn't put any new schemes in. We just did what we did better. And what we actually saw when we came into January of this year, the number of patients waiting in an acute hospital bed, such as Royal Stoke or County Hospital, to go into what we call a pathway to community hospital rehabilitation bed. In 24-25, those numbers peaked around 70 to 80 patients at the height. As we came through into 25-26 in January, we had one day where we were in the teens. And didn't even tip into the 20 mark. We peaked around the 30s on our busiest day as we came through. So it really shows us that actually, if we don't do things different, just do what we know we need to do a little bit better, we do see some benefits as we go through. But that doesn't say that we're not going to be innovative with our approach and support the left shift and the hospital to community piece as we go through. We need to be realistic and deliverable with our time frame, but our available resources as well, so that we work our way through each of the schemes that we have to support winter. We need to be data and evidence-based and have that real public health lens to support our population need and address the health inequalities as we go through. We need to have our providers undertake some more robust demand and capacity planning so that we can understand that's the foundation of the plan. That's where we know we're going to hit our pinch points, and we can see those as we come through. One of the things that I didn't mention in 25-26 is we felt the actual impact of winter earlier than was planned and modelled, and that wasn't unique to Staffordshire and Stoke-on-Trent. That was both a regional and a national hit that was seen as well, and related to our sort of flu and respiratory type illnesses. They came really early, sort of mid-October, end of October, and that actually drove one of our 2 critical incidents that we had last year as we go through. We've got our system-wide metrics. We need to do a little bit more work around how we agree those and how we have a consistent dashboard so that we can keep that forward view going. And as we said before, we need to simplify our governance. We move it. There we go. So key patient pathway priorities that we've agreed going into 26-27 are vaccination programmes. Worked really well last year. We vaccinated more of our population and worked through. What we need to do is continue to prioritise our elderly, frail and the staff cohort within there so that we can really help our patients. Looking at our virtual wards, so these are where we can give hospital consultant level care within a patient's own home, how we can integrate those with what we call our pathway 1 step up, step down provision. So that's where there's patients that need a little bit more in that care support, so that actually if we can integrate those two together, we can support more patients to be seen at home in their own communities where clinically appropriate. Expanding our 7-day working as we go through, looking at our high volume user and high intensity user services, so getting right into those sort of front door services where we're seeing these patients that continually attend, where either we haven't addressed their needs or they have a slightly differing need that caused them to attend, doing some work specifically around those cohorts to try and avoid them having to come into a hospital setting, making sure they're picked up by neighbourhood teams, picked up in the community and really supported rather than those escalations of care as they go through. Elective care we've spoken about, we need to make sure that isn't compromised as we go through. And then ensuring that all of the pathways that we work towards do align with the 10-year plan and our neighbourhood health agenda, so working around that in neighbourhood health teams. The last slide is new and it's slightly adjusted this morning as we received the NHS England National Winter Letter late on Friday. So we've been waiting for it for some time, so this will differ slightly in the timelines to what was in the written paper that was submitted a couple of weeks ago. So you can see the journey that we've been on in terms of the Winter Lessons Learned event, how we've started getting our provider schemes as we go through. During July, and we're coming towards the end of July now, we'll start receiving our providers' internal plans. As we go through. The winter letter that we did receive on Friday rebased the timelines from what was originally expected. So what we now need to do is submit our initial winter plan through our relevant urgent and emergency care board governance on the 21st of August. And then each provider organisation and the integrated care board need to take some assurance statements and our, I want to say final plan, but the winter plan is a living document, so it will be final at that moment in time with our intentions, but we have to adapt that to respond to pressures as we see them coming through winter on the 30th of September and submit all of those through to NHS England. And that brings us to the end. Thank you.
Okay, thank you very much for your presentation. Can I just ask that that is circulated with us after the meeting. Thank you. Okay, so we have Councillor Luca would like to ask some questions.
Okay. Again, thank you, Chair, and thank you Officer, for a very detailed explanation there. But, I mean, I'm not doing it anymore, but last year I was driving ambulances. I mean, so I know last year, within a very, very short period where we came in to the winter period, Stoke had to declare an emergency within the winter detail. So, my question's going to be, because obviously it was such an early point that you declared it, what actually extra finances and facilities did you have to actually implement, and what have you learned by that for this year coming?
Yeah, so critical incidents we go through is a mechanism that supports us to be able to respond in a different way with patients as we go through. So it allows, we have a system escalation plan that's agreed with all partners that has some really set sort of boundaries and actions that will be taken. There's about 500 actions all told in there, so I can't go into all of the detail of all the individual actions. But in terms of when we had the critical incidents and what we went through, it's around how we prioritise services differently. So one of the actions, for example, is a clinician assessment will be undertaken and look at some of our elective care programme that we spoke about and deliver that care differently, maybe stand down some of our outpatient clinics so that we can release that clinical speciality, particularly at a consultant level, back onto the shop floor, and that's one action that we did undertake last year as we go through. We'll look at commissioning some of our capacity differently. Now, we know that what we call spot beds, so these are community pathway beds within care and nursing homes, is not ideal because what we usually find is we can have 2 patients here and then we'll have 3 patients over there. It's difficult in the care market to go and say, right, we need 20 beds, for example, and there's very rarely a location that's got 20 patients in one place. And if we do that, it's great, but when they're dotted around, it actually makes us less efficient and can actually cause further delays. So last winter we commissioned an additional 25 spot beds in response to the critical incident, and then stepped up and adjusted those throughout winter to respond. So even though we may have come out of a critical incident, they just didn't stop. We just kept them and moved them and adjusted them as we needed. So that gives you a flavour of some of the actions that we would have taken. But as I say, there's quite a significant number. Sorry if I just close off the last part, because I didn't close off the last part. In terms of how we take that learning into this year, once a critical incident's happened and been stood down, we undertake 2 reviews. We do what we call a hot debrief. That's within 48 hours of the incident, so that we can take any immediate learning to adjust our plan as we go through. And then we undertake a cold debrief, for want of a better term. It's usually within 28 days. And what that allows us to do is to make sure we've assessed all of the impacts, we've taken all that learning, and that does build into our plan as we go through. So we made some adjustments last winter, we'll make some adjustments to the plan this year, and as I say, when we call it a sort of the final winter plan that has to go in on the 30th of September, it's about as final as that moment in time, because we'll respond to those on a daily basis.
Okay, thank you for that. I was just going to ask you if you could actually finish the last part, but you remembered and you actually did it, so thank you very much.
Okay. I quickly just want to mention we have spoken previously. We'd like to request for a briefing report on the actual critical incidents that have happened previously. Is that okay?
Yes, no problem. So I think we brought or colleagues brought to the committee last year a review of Winter's 24-25's critical incident, because we had quite a number during that year. We can happy to bring back a review of 25-26's incidents. That's not a problem. Could I suggest to the committee, we'll obviously be bringing the 26-27 plan to you. So for ratification sort of discussion September, October, are you happy if we bring those 2 together?
I'd rather... and I think the committee might agree that we get them as soon as possible.
Yep, no problem.
And then obviously we can discuss it at that meeting, if that's okay.
Yep, no problem. We'll
Okay,
do that.
thank you very much. Councillor Mandry?
So in paragraph 8, you have a bullet point on about ambulance response times, and there is a sentence saying performance remains significantly above the standards. What framework do you actually have in place to bring it back down towards the national standards then, if times are above it?
So in terms of the Category 2 response times, there's a number of steps and actions that are being taken both locally within our NHS partners, but also our ambulance service contractors commissioned collaboratively across the Midlands, led by Black Country and BSOL ICB, as we go through. So what we're doing is working together around how those pieces work. So there is a programme of work within the ambulance service, looking around the cohorts of patients that are in there, looking to do things in their control rooms differently with what we call the clinical validation team. So assessing those patients and making sure that we get the right patients to the right pathway and get the right and most appropriate response. There's a significant number of patients that call 999 that actually don't need a physical ambulance to respond to them, that can be directed to alternative services and support. So there's been a lot of work with the clinical validation team and what happens in that arena to support the responses there. Locally, our biggest challenge now is around addressing our ambulance handover delays. And I'm going to speak in general, but particularly focused around the Royal Stoke site, because that is driving one of our key challenges. What we know is if we are offloading ambulances in a more timely manner, then patient ambulances are able to respond quicker back out into the community, and we achieve those ambulance response times. We can see that. So this weekend, we've offloaded around 92% of our ambulances within 45 minutes at Royal Stoke, and actually achieved under the 18-minute Category 2 response time all weekend, this weekend, as we go through. So there's a direct correlation in there. So as commissioners, what we're working with UH&M as the service provider is to work through their improvement programmes. They've got a 5 work stream UEC improvement programme. Within there is a specific work stream around work stream 2 that focuses on their front door processes at the ambulances when they arrive in the emergency department, both for ambulances that arrive but also patients that walk in. Because what we quite often find is a patient comes in on an ambulance, but there may be a more acutely unwell patient that makes their own way. And what we're seeing with the higher acuity is those patients that are now walking in are actually needing to take space in what would have traditionally been the ambulance offload area as they work their way through. So it's now how they operate their whole front door model. So we're working to oversee and support that programme of work, but also make sure all system partners are engaged to go through. And that's probably one of our single most improvements that will be managed against that.
Thank you very much for your great question. Councillor Griffiths.
Thank you, Chair, and thank you for your presentation. You kind of touched on it right at the end, but I'd already put my hand up. But it was the demand versus modelling. And like you said, last year, it's not winter start, it didn't get cold early, but the respiratory spike happened a lot earlier than thought. And we were left in a situation where extra capacity was due to come online, but it all happened earlier, so we were in a struggle, but probably was what caused the critical incidents. But so what I want to know is, going forward, is there a way of having more flexibility so we could have brought that capacity forward and brought it online earlier? I understand you've got limited resources, so whether that means you've got to end it earlier in February, just your thoughts on that, please.
Yeah, no problem. It's a really good question. It's one of these challenges that we are working to address, and I'll go through some of the things that we're looking at that. What we can't ever guarantee is that the demands will come at the same time this year that they did last year. So we do our modelling based over a number of years, historical models, to try and capture things as we go through, but last year was the earliest. In terms of the schemes and can we move them around, last year we were quite sort of stuck and rigid around what we'd got. Some of our community pathways that we could do, we did bring online quicker and sooner, so things like the spot beds and things, and then tailored those off early in the February time period as we go through. What we are aiming to do, and we're still working through our finalised bed model with providers this year, is we are now decompressing some of our community capacity, and we have already decompressed some of our community capacity, physical capacity, so that we have that available to us to open as we need to. Now that comes with quite a significant sort of caveat, is to open a bay of wards, you've got to have staff to do that. Now, if you're opening a bay within an existing ward, within, for example, Royal Stoke Hospital, that's usually easier. I'm not saying it's easy, but it's easier to find the staff to adjust there. Some of our sites that we will look at in our winter plan are some of our community hospitals. So Cheadle Hospital, for example, we used beds in there last year. We're likely to use beds in there again this year. Because that isn't in use normally, we have to recruit the staff into those. So those are the ones where we can do a little bit, but it's not as flexible. But that is one of the key points of the plan this year, is to try and be a little bit more adaptable, and by earlier planning and earlier agreement of sort of the finances and the resources that are available, that's what we intend to do with that.
If I could just add something to that, Chair, it is a really good question, and it's the public can help us with this by taking up the offer of vaccinations, and if we can improve the uptake, then that would, in principle, reduce the impact of any early onset flu if that catches us by surprise again. And so what we will be doing as an ICB to support that is we're framing a winter communications campaign at the moment, which will possibly have 3 pillars in it. One of them is think vaccination. Second one is think self-care, to try to look after yourself as best you can. And then the third one, to think which service. And that's quite a well-trodden one, the think which service, and that includes things like, do you really need to go to hospital when actually your pharmacist may be able to help you first? So the uptake of vaccinations is something that we're going to message very strongly this year to the public, and they can really help us by taking the opportunity as soon as it becomes available for that. I know it's a tricky ask on a day like today, but now is the time that we will be starting to frame how are we going to message that, and any help the public can give us by encouraging families and friends to get vaccinated will help us in the hospitals to counter those unexpected early onset peaks of pressure.
Thank you very much. Thank you. Thank you, Councillor Griffiths. Councillor Edgeler.
Thank you very much, Chairman, and thank you for your report. Okay, sorry. First of all, I'm really pleased to hear the good work that's going on at County Hospital in Stafford, but my message really is about the elderly. Do you have any talks or any with the firefighting service, knowing that they go into people's homes and they can see probably the elderly, especially in the winter time, have got problems, health problems, and picking and being able to contact yourselves so they can help with these people before it degenerates into something really bad. So my question is, do you have contacts with the fire service, and do they come into your communications? And you said about getting the message out about vaccinations and that. I think one good thing is to put it into the libraries and also put it onto the doctors' surgeries, because doctors' surgeries, you know, getting the message out there to especially the elderly. So, yeah, thank you for that.
No problem. So if I address the fire service question before, we actually commissioned 2 services from Staffordshire Fire and Rescue Service to support us in our emergency and urgent care pathways. So they work both in the pre-hospital and the post-hospital. So in the pre-hospital space, they actually operate our falls response service across Staffordshire and Stoke-on-Trent. So they use firefighters and associated colleagues to actually respond to what we call green falls, so low-level falls, predominantly elderly patients that haven't collapsed, have just slipped, maybe tripped over something, fallen to the floor, and they actually go out through our Integrated Care Coordination Centre, our ICC. They go out and pick those patients up, make sure they're safe, well, identify any sort of issues or concerns, undertake what they call a safe and well check when they're taking those patients out. So they do work work with us there. That's also enabled us to build those relationships for if they identify a problem when they're responding to a fire call as normal, they know who to contact, they know the access route to bring back in. One of the other areas that they work with us in what we call our hospital to home service. So again, it's colleagues from the fire service that are supporting discharges from the hospital, and that's done in partnership with colleagues from the local authority through the Better Care Fund. So they actually go, they discharge the patients, they settle them in at home. If they need a key safe putting up because they're no longer able to get to the door, they'll install a key safe, they'll do a fire safety check, they put heating in, and they'll do that. And what that's actually helped us find is patients that go home with that service usually or tend to stay at home, whereas other patients that have gone home who haven't had that settling in element potentially have a risk to bounce back in through a failed discharge and back in there. So again, they're able to support us through there. And that's something that's been operating now for last year was the second year. It's commissioned for winter again this year, and one of the conversations is around how do we do this differently or do more of it so that we can support a wider geography if needs be. Just in terms of the vaccinations, GP practices are key in that comms campaign as we go through. Obviously, primary care networks, GPs are the ones that will deliver the vast majority of the vaccination programme for us. So that is key, and we can make sure we feed back with our comms colleagues around things like libraries and make sure we're getting that full reach across.
Thank you, Chair. It's just that you never mentioned the firefighters in your report and that, so I'm really pleased to hear what you've just said. Thank you.
Chair, can I just add a little addendum to Jack's comment about vaccinations? And GPs are very important for vaccination, but we shouldn't forget the role of the pharmacies as well now in the vaccination scheme. They provide, and you know, it increases our capacity to get everyone vaccinated. So I just wanted to give them a shout out so that we hadn't forgotten them.
I'd actually like to second Councillor Edger's thoughts on the fire service involvement. I think that's actually excellent. Councillor Wallins.
Thank you, Chair, and thank you for the detailed report as well. So I've got a couple of questions on this item in particular. On page 28.10 of the report states that staff fatigue and ongoing exposure to high-risk conditions reduces resilience. I was wondering what additional support has been induced to improve workforce well-being before the winter arrives? Thank you.
Press the right button. Thank you for that. So in terms of staff wellbeing, as we work our way through, our chief people officers have been working collectively across the system so that they can work with their individual frontline teams. As we went through 25-26, we actually had a programme of work supported by our people and led by our people hub, not supported by, I should say, that really focused around different staff wellbeing initiatives that were able to be put into place. So things like how they, one of the biggest challenges is if you're unwell, actually please don't come to work. There's a real sort of staff feeling that we just keep coming in, we're here, we're doing it for the patients we work through, but actually take that time, take that rest. If you come into work, you know, you've got a cough, cold, potentially got the flu, you actually risk spreading that, but also you don't recover as well. And that's one of the key focuses that we did with staff last year, is about take that appropriate time, take that appropriate rest, making sure that people are taking things like their leave, their non-working days, their rest days, having a real focus, because we know in the times of challenge and pressure, when we, especially when we try and spin things up, like your colleague next to you said before, around can we do things differently, can we open things more quickly, we often, in the very early days, when we do it quickly, rely on overtime, goodwill, things like that. So actually it's about really making sure that staff take that time, have those comms campaigns, get on the ground with them, support them through their line managers to make sure we're having those types of conversations with them. Vaccinations was a key one this year, so we set a stretch target to vaccinate additional 5% of our workforce this year, and that's something that we actually achieved, and we felt that benefit.
Thank you. And just go back into what you said about overtime. You know, when you offer staff overtime, is it how much overtime is there available? Is it loads? Is there barely minimum? I mean, I know it might be a shot in the dark.
It varies greatly. It depends on the service and it depends on the need. So, for example, if we've seen a significant rise in presentations of children with respiratory illnesses that can be supported by primary care and paediatricians, then there'll be more available in that area. So it'll be tailored depending on what the needs are. So I couldn't say to you there was X percentage or X number of hours and this % was taken up as we go through, because it just does adjust on a weekly and in some case daily and hourly basis just to respond to the patient needs and demands.
And you're going back to the staff shortages and so forth, how much short are you of staff to have a, what's it called? Yeah, that's the one, yeah. So obviously to be in the okay range.
So as Mish said before, in terms of individual provider staffing sort of gaps and vacancies and percentages, that's something that would be better directed to the individual organisations. Again, what we can say is we know it fluctuates, we know it has different types of demand. Because we haven't finalised the 26-27 plan at this stage, what I wouldn't be able to do is to give you a percentage to say we've got this gap against the staffing resource that we need as we go through the plan. We're still in those quite, not early, but detailed sort of numbers-driven conversations around what the schemes are rather than how much of all of the staffing that we'll need against that. But that's something when we bring the 26-27 plan to the committee, we can bring more detail on, no problem.
Thank you. And back to the staffing levels, are they expected to improve this winter, or are they remaining to be the same compared to like the previous years?
I think we will always plan to improve on our position year on year, and that's something that we achieved 25-26 from our 24-25 position. As I say, at this point it's still a little bit too early until we finalised all of the individual schemes and what staffing resources sat behind those, but happy to, when we come back with the winter plan, as I say, get our workforce colleagues to give us a little bit more detail to be able to support that.
Thank you. And just one more question. Sorry for hogging the mic and so forth. I know you mentioned in your presentation on the PowerPoints that the elective care was affected by winter pressures. I was wondering, how will you protect planned operations from being cancelled this coming winter?
So one of our key areas to try and focus that is around using the county hospital site differently. So that has opened as it still has urgent and emergency care services within the site, and there's no intention to adjust or remove those services as we go through, just to be clear. But it's around how we can use some of that capacity differently to use it as an elective hub, so potentially move more of our activity down to the county side from an elective perspective, so that we can use the beds in the bed base within Royal Stoke to deal with those more acutely unwell patients as we go through. As we model sort of our demand and capacity in our beds, we know our bigger focus and our biggest challenge sits in the Royal Stoke side, so it's how we can respond through there whilst we are still able to maintain some of those services as we go through. So, for example, dedicating specific wards as cold wards or elective wards, and actually cohorting our elective patients into those single wards rather than having a mixture of patients on different wards, so that we can keep our urgent emergency care wards, for want of a better term, and our elective wards separately. So that's one of the key steps that we're going to be taking. We did that with one of the wards at County Hospital last year, and we really felt the benefit of that, that even though we did impact on the capacity, we impacted on it a lot less than when we did in 24-25.
Fantastic, thank you for that.
Just to quickly go off the back of Councillor Wallins's questions on workforce, what measurable improvements do you expect in your workforce's well-being this winter, and how will you know whether the actions you have taken have improved the fatigue and resilience of your workforce?
Thank you. It's sometimes hard to gauge the morale of the staff, but it does get severely tested in winter, as we all know, and that can manifest in sickness absence rates at different times. I spoke earlier of our intention to communicate really clearly, and it will be across a broad spectrum, including the GP surgeries, with our patients and public about what's going on, trying to empower them to select the right services and so forth. We will also add to that internal communicating with the staff. Having managed multiple emergency departments over the years, it's a really lonely place in winter, and you often feel that you are the place of last resort where anybody that can't get seen anywhere else will come into the department, and you often feel, especially as you go into the night, that you're on your own because you're open 24 hours and the rest of the hospital has largely gone to sleep. So it's really important that we let the staff know that they aren't alone in these things, to let them know of all the broader initiatives that are going on, and just give them that sense that we're all in this together. It's a real team effort, not just within the hospital, but the other supporting organisations that we rely on to do it. And if we let the staff know this sort of messaging, that you aren't on your own, that it is genuinely a team effort, things are going to be different this time. Yes, it's tough at the moment, but everybody's going to help. That sort of messaging is a really positive thing to receive if you're in a very high-pressure emergency department. So that is something that we will use to the best effect we can this year. You obviously need to be a bit sparing and really selective about it. If you say that every day, then the message tends to wear off. But we will be letting the staff know what it is we're doing, why we're doing it, and why it will be better. And we would expect that to play through. It's really difficult to do cause and effect on that or the vaccination program to sickness rates, but we do recognise that burnout, particularly for patients in the the staff in the emergency departments, is a real issue. But we will be looking at staff sickness, and that is a really good bellwether of the morale and how the staff are getting on.
So what are the measurable improvements that you're going to implement, and how are we going to know that that's worked?
I think I don't have a measurable figure in mind, but now that you've raised it, that is something we'll take away and have a look at as we develop our plan. But I think generally speaking, we look for year-on-year improvement in the uptake of vaccinations, and we would also look for year-on-year improvement on the sickness absence rate, which is multifactorial, of course. It's not just vaccinations, it's not just how hard they're working, but I think it is a good bellwether of how the staff are getting on. So we will take that away, and when we come back to brief you on the winter plan in circa September, October, we'll make sure we include that.
Thank you very much. Councillor Walling, is that to go off the back of what I've just said? Okay.
Thank you, Chair. And just to follow on with staff burnout and so forth, I know from my experience as a bus driver for Arriva Tamworth, I know this is a completely different sector, there was about 3 or 4 staff short of having sufficient staff, and there was loads of overtime available. And it gets to the point where the people in the office or the higher-ups struggle to obviously allocate the overtime, and then they force emotional blackmail on the workers to try and get the overtime sorted. I was just wondering if has there been any reports of emotional blackmail or pressure on staff to accept overtime?
I'm unsure what you mean by emotional blackmail, Councillor Wallins.
In other words,
I'm not sure if that's appropriate language. Can you explain it in a different way?
Oh, in other words, has there been pressure in any way, shape or form towards staff to take on that overload of overtime?
Certainly nothing that we've been aware of. People, nursing staff and clinicians generally will offer their availability on a bank arrangement, and that people will be contacted or they will observe if there's shifts that are available, and people will take them up. But there's no question that people aren't pressured into doing this. They're not blackmailed. Everyone knows that they're working very hard. And if people are not taking up a shift, they're not taking a shift for a reason. And there's also, of course, the availability of agency. So you can work, there are other ways of filling gaps than just going to the same people all the time. So the short answer is no, we're not aware of that. If we were aware of it, then obviously we would be concerned, but as I said, we've got nothing to indicate that.
Thank you, Chair. If I could just add to that. In my experience, the clinical staff, in particular in the NHS, it's more them putting pressure on themselves to come in. When they know that their department is under pressure, no matter how tired they are, they will often pressurise themselves to come in when arguably they shouldn't. And that's something we really do need to look out for. I have seen elsewhere where it's been difficult to get staff to pick up bank shifts, despite the fact that, let's be realistic, everyone's feeling the cost of living at the moment, and extra money is always welcome, but sometimes you get to the point that staff are prioritising time off because they're so tired rather than taking up opportunities for bank shifts. And that's quite a stark thing that I've only really seen in the last few years. Notwithstanding how hard people are, they're having to prioritise their own time off rather than pick shifts up. So it's something we'll watch out for, but full circle to your original question, I too am not aware of pressure being put on staff to pick up shifts, and they really don't have to. It's more the staff themselves that will pressurise themselves to come in when they probably shouldn't.
I think Health Watch wanted to come in, so Mr. Bassett, if you want to, as they are the voice more of people on the ground.
I was just going to reflect that I did an enter and view visit to Burton A&E in the middle of April, and I asked the matrons how many vacancies have you got and how had the vacancy freeze within the trust affected them. And this was like the back half of winter. They got 103 staff posts, and they had 25 vacancies that were frozen in the vacancy freeze in the second half of winter. They were being released and they were starting to recruit in April, but it just seemed a bit strange that in the middle of winter you got 25 vacancies on the A&E nursing staff for Burton Hospital. So just the finances of the trust, they were saving lots of money, weren't they? Because they've got to hit their financial target, but at the same time, lots of vacancies were being frozen. They must have covered, they were covering it, they said they managed, but it must have been putting pressure on other people and bank staff and so on and so forth. But maybe it's just something you need to keep an eye on, that's all.
I do agree, I really do. The bigger picture, of course, is that nationally we have to cut the cost of what we're doing, and it's been well documented over previous years that the NHS has received more funding, and we've got to really make every pound of that count, and part of that is bearing down on cost and holding trusts and ICBs to account for delivery of the financial plans that we've all committed to. And I'm with you wholeheartedly that does not seem right at the time, but equally we can't overspend with in the way that may have happened in previous years, where we're in a completely different environment on that now. So we do have to balance bearing down on cost versus delivering the operational outputs. Something I would just add, because I can see you do want to come back, Councillor, is as we settle on where we won't have a lot of funding for the ICB to commit to schemes, but one of the things we're going to try to do is to keep a reserve of funding in our back pocket, so to speak, so that at a time of particular need during winter, we can commit that reserve as an intervention. Now, you can burn through a lot of money very quickly on staff costs, as you can imagine, but we will try to maintain a reserve so that if there is some critical point of challenge, then we can intervene as an ICB rather than expecting a trust to make an awful decision about do they overspend and get into trouble, or do they commit to the operational safety of the department.
So, from what I understand is, and from what I've heard through the presentation, what you've just said, is that would you say that many of the services across our hospitals would improve if you had substantially more funding. Staff and extra beds, wards, services, etc.
I think any organisation, especially any of our partners across the rest of the public sector, the police, the fire and rescue, we would always welcome more funding, but it is really important that we spend any funding that we've got wisely, and we do need to absolutely satisfy ourselves that what we have already is being used in the most efficient manner possible. And this sort of connects with the presentation that Mish gave in the previous item, and why we want to right place the care of patients, because if we can intervene early enough in a neighbourhood to prevent a patient's condition from deteriorating, it's far cheaper for them to be treated in that manner than in a hospital bed for lengthy lengths of stay. I know that's broadening your question a lot, but of course, if more funding were available, we would try to use it wisely. But in the meantime, we've got to use what we've got to the very best effect, which is what we're trying to do.
There was just one other point that, from Healthwatch perspective, that might be helpful. We've had some good stories about people who've been to the community hospital with minor injuries. For example, somebody who fell, damaged their shoulder, went to Lichfield Hospital, was seen, x-rayed and discharged in 55 minutes. And perhaps you could do some local targeting of populations around the community hospitals that have got minor injuries units to encourage people to use them a bit more. I mean, we hear people from Sutton Coldfield who go to Lichfield rather than go to Good Hope Hospital because they know they'll get seen quicker. So perhaps, a bit more work on highlighting what's available in your locality would be a good thing, as part of the neighbourhood stuff as well, isn't it, I suppose?
That's a really helpful comment, and it's great to hear that people are getting good service from our local minor injury units. I think Gareth talked earlier on about one of the pillars that they were doing is about the communications to populations, and one of those will definitely, part of that is telling people where to go appropriately for care. The other thing that we probably should promote is 111, because if you're 111 is absolutely aware of where services are. So if people are unsure, then ring 111 and you'll get directed to an appropriate minor.
One of the things you get told with 111 is go to the A&E department and they'll be expecting you, and some people seem to be under the illusion they're getting an appointment, so that rapidly gets dismissed when you get to the reception desk.
So I take the point about people's expectations. I think it's important, though, that 111 has sight of all the services. It does tend to, being honest, on the side of safety. So some patients will get escalated to potentially a ED or a 999 service, but the vast majority will be directed to other services, including self-care. So 111 is a very useful resource, and the online version as well, of course.
Okay, thank you. Was it Councillor Luca you wanted to ask something? I think Councillor Greatrex as well. So Councillor Luca.
Okay, thank you. Just taking it back to the ambulance services, and you mentioned also about discharge. One of the things that we trialled last year was actually having a dedicated ambulance for the discharge lounge. And what that actually did is it freed up a lot of time. It helped obviously the NHS staff within the discharge lounge. It freed up beds because we could actually, it's going to sound awful, but we were able to get people out of the hospital environment a lot quicker because of having that dedicated unit. And in turn, it also had a knock-on effect because when we knew the weather conditions were poor, certain addresses keep popping up in the system, as you'll be aware of, where you get people in, quite often on a regular basis. And we learned that some of these addresses within the winter period, the type of ambulance that could be needed wasn't the ambulance that we were crewing that day. So it actually, again, it had a saving of cost and time, because we weren't actually basically sending an ambulance out to an area where we would have to bring the patient back because we can't get to the house. So this is more of a recommendation. You might want to actually look at that system to see if you can incorporate it while you actually put this plan together, because it did actually save a lot of time and stress for both the services, the patients, and our financial costs.
Thank you for that. Yeah, just in terms of ambulance service response, as we say, the review gives you a level of the information. One of the schemes that we do commission, we've commissioned each year and we will commission again going into 26, 27, is additional transport capacity. So we commissioned additional crews for each of the acute sites across Staffordshire, but also of our neighbours. So, for example, New Cross, Good Hope, that have large proportions of Staffordshire activity flowing into them just because of where they are against where residents live. It's really good to hear that when we do that, that's had a positive impact, as you rightly say, sort of focusing it in makes everything more efficient, doesn't it, as we go through. So we'll take that feedback on board and hear about the positive experience and make sure that's a fundamental part of our NEPS providers plans again, going into 26, 27.
Okay, thank you very much. I think Councillor Greatrex had a question off the back of for the staffing.
It's a different subject.
It's a different subject.
Yeah.
Okay. Councillor Norman actually wanted, if that's okay. Councillor Norman.
Thank you, Chair. I was going to ask questions, more details, some practical examples with regard to Section 11, the system learning and strategic themes on page 28, like admission, avoidance, discharge and flow, because it's rather high level language there, and I wanted practical examples. Now, Mr Butler has given quite a few examples and others throughout the meet, but what we've always wanted on the Scrutiny Committee to help us is to have all papers before we meet, so we can read those papers and ask more pertinent questions without having to listen to a lot of information on the day. So at least I'm grateful for those practical examples and look forward to reading them later on. But there's those 5 headings there, 5 bullet points, and you did mention targets. You mentioned the timeline. You did mention targets as well, the odd target every now and again. Are there general targets for those 5 bullet points? In other words, where you can get warning flags if they're not being met? And I appreciate that you can't predict the weather and all the rest of it. So, you know, I'm just amazed at being able to get a grip with the winter situation. But if there are targets there and there are flags, we could be told about those, because there might be barriers. For example, in the discharge one, you're relying on the community social care, you're relying on the voluntary sector. And you might have problems with them. We, as a Scrutiny Committee, can actually invite them in and say, look, there's a problem here, you know. So we can be your lover boys on your side, really, but in a nice way, obviously. So is it possible for you to give us regular updates in the winter period there, as best as practical, and letting us know particularly where there are any warning problems that you need help with? So we've been your critical friend. How can we help? That's what I wanted to say, Chair. Thanks. Thank you.
So there are a number of metrics that we monitor as we go through. We have a system called Shrewd, which basically gives us real-time data on hundreds, if not probably thousands by now, of metrics that are all RAG rated, that we use in our system coordination centre to manage our calls and conversations with providers and escalations on a daily basis. So we have those pieces through, and we actually have a set of what we call our daily metrics, strategic metrics, that were developed in response to the 24-25 critical incidents that allow us then to have that it's a much smaller set, but they are the really big hitting items. So discharge delays, for example, admission avoidance, challenges that we face that we go through. In terms of how we feed that information back through, we have a governance process that goes through. We can review and build into that some highlight reports and have a conversation, think about how we could bring that into the OSC arena potentially. So it's not a no, we just need to think about how we fit it in so that it's still relevant at the time in which you receive it.
Yeah, if I can, it's really just having some bullet points, really, so where you might need help from, or where we could be of help to. That's it, and give some idea, because I've realised I want all that information, and that information might change, well, presumably it does change day from day, or, well, you said you have a daily rag rate. But I'm glad to hear you got that, but I'm really saying I think Scrutiny can help, possibly help as you go, and I certainly wish you well this winter. Obviously, I'll be inoculated long before the problems start.
Okay, thank you. Thank you for your question. Councillor Greatrex.
I'm going to back up what Councillor Norman's just said, because I'd planned to say this anyway. Comment first. Both Phil and Jack went through a presentation which went rather rapidly. We'd had an 8-page report which had been circulated before, and I certainly have pored over that and had a lot of detail, and I've got questions relating to that report. The one that was on screen, we haven't got a copy of, and it's gone, it's washed over. So just a point for the future, as Councillor Norman said, we could do with having it beforehand so we can study it. In relation to what we've got on the presentation that's been circulated, page 23 of our document is what I think you're calling the pillar approach to the winter surge plan, which is the one with 13 columns in. And as it says, it's got a holistic approach, hopefully covering all 13 areas of measure. And you just mentioned most recently, Jack, about the metrics. It would be useful for us to know that some of these measures are working. So, for instance, Gareth had referred to the benefits of having all the childhood vaccination figures. We could do with knowing how many, perhaps in 25, 26, there were compared to previous years, whether that's working. Things like respiratory offer, get it right, the respiratory offer, the additional capacity in primary care, I presume that's additional beds, expanded community response offer, all of those things that would be useful to have some form of metric for us to see that it's making progress. If you're going to put this up in front of us once a year, it'd be nice to know there'd be some progress on those things. So that's a comment stroke question, whether that's possible.
Thank you, Councillor, for that. I have to apologise to the committee for us not providing the additional detail, and we will absolutely do that going forward. When we return in September, October, we will include those changes on the previous window experience. So some of it is covered in the report that we've provided today, but we'll make sure that that's really clear on the things that we've heard today that the committee's interested in, and also just to bridge to the earlier comment from Councillor Norman, thank you for that offer for the committee to support. We do try to resolve issues with our partners, as you'd expect, but if there is something specific that we think the committee could just add a bit of focus to and support, we'll bring that back as well when we return in the autumn.
And I've got two other questions. I think it was Jack that referred to Saturday working. With my experience of hospitals on a Saturday, again, it's the holistic approach. Nothing much happens if some of the services aren't there. You've really got to have all the services to make it really worthwhile. For instance, if the ward doctor's not there on a Saturday, nothing tends to move too quickly and people are strapped in for the weekend. So I just wonder, in terms of the workforce pressures, whether it's possible to get all of the measures all happening at the same time?
Yes, so thank you for the question. In terms of the sort of 7-day working is a core requirement and a core focus to ensure that we keep flow maintaining, as you say, so that we don't get those sort of bottleneck positions as we go through. It's a real key push of the ICB as we move forward with our providers to make sure that we keep that sustained 7-day service. In terms of the workforce, there's almost a tipping point in certain areas, and particularly in certain specialities, whereby there isn't enough demand consistently, that then the workforce is there to support through. But there are always, just to give you some assurance, there are always staff that are either on call or available in an escalation process that can support to try and avoid any of those delays. But we do recognise that things not stopping but potentially slowing down at a weekend is still one of the areas of challenge that needs to have additional focus. And that's why last year we felt discharge was the in 24-25 we felt that discharge was the area, and that's why during 25-26 we had that real focus around the 7-day discharge facilitation focus and process so that can support there. But take on board that point. Steve, do you want to?
Yeah, and I think it's a really good point, actually. But I think it's recognised by the providers as well. So Jack mentioned the UHM internal improvement workstreams for winter, and one of them is workstream 3 is particularly looking around ward processes and making sure that, you know, patients who are ready for discharge at a weekend are discharged at a weekend. So making sure that those discharge medications are sorted out, making sure that the discharge letter is sorted out. So that, because those are key blockers in terms of people getting home. So it is absolutely recognised, and the hospital is trying to improve it, not just at the weekends, but during the weeks as well.
Yes, Chairman, I certainly recognise that. People being held in on Sunday, waiting for somebody to sign them off to get out on Monday. The last question is about the page 27, which is the differences in process and flows relating to the emergency 4-hour performance. I think the text is saying it's below the national average for Stoke and Burton, and I presume Gavin would also be able to, Gareth would be able to refer to what happens at Telford, I would imagine, in Shropshire. I think a lot must be dependent on the design of the hospital, and I can only speak to my knowledge of Burton, where conveniently the ramp is at the front of the hospital. You're straight in from the ramp into the emergency ward, and there's minimal amount of transfer time. That must make a difference, and I'm not sure whether it's the design of the hospital needs to be looked at. Obviously, looking year on year, these sort of things don't get looked at. So is there any strategic look at the designs?
Thank you. So I think we're talking about sort of ambulance handover delays when you mentioned about ramps and being there. So yeah, at each of our acute sites, ambulance offload areas and ramps are literally next to the entrance point as they go through, so it's the same over at Royal Stoke. One of the challenges that we have is around the capacity in terms of the space that's available, particularly if we look at Royal Stoke around the number of ambulance offload areas and sort of cubicles and spaces versus the number of ambulances that they receive per hour. Now, there is a difference. You know, we have to be honest with that. There is a set number of cubicles. There is a set number of well, there isn't a set number, but there's a varying number of ambulances, but usually you get an idea of roughly how many are coming by hour through our forecasting as we go through. And there is a difference between those, which is why the real focus is across the whole patient pathway, because what we actually need is the flow, so that those patients coming by ambulance that come into that ambulance assessment area are actually then moved quite quickly once they've had their initial assessment and triage and sort of stabilisation, then move out into the wider emergency department. For that to happen, the patients that are having those more longer treatments within the department, the main department, are then moved out into a ward or discharge if they need to. So there is a physical estates element to this, you are right. There is a number of capital programmes and estate programmes going on, both strategically but also with teams on the ground that know they can use space a little bit differently as we go through, and that's a key part of both UHM and UHDB's improvement programmes. So we have recently invested through some national monies in an urgent treatment centre at the Burton Queen's Hospital that's given them some additional capacity for those lower level attendances. That means they can then use their wider traditional ED space differently. That's in and that's built, so that's why we've probably seen that impact and improvement in Burton Queen's during 25-26 and coming into 26-27. There is also a build in progress at the moment for an urgent treatment centre at the Royal Stoke site that will be opening in the coming weeks, and we as an ICB board in June took the we are July now, aren't we? Yes, in June, took the designation decision to designate a urgent treatment centre there. So again, that means there's going to be a cohort of activity that's previously been in the main department, the main building, that will move into the new urgent treatment centre. So again, as we go into 26-27, use the estate differently. So there's both some operational on the ground pieces of work, but also some longer term strategic pieces of work that are being taken to support and address those challenges.
Okay, thank you for your question. Councillor Broome.
Thank you very much, Chair. Thanks, Jack, for a great presentation. You're bearing up under the pressure. Lots of questions. I'll go back to Councillor Luca's question. You're on about managing resources, and then I think, is it Gary or Gareth? Gareth.
It's Gareth.
Gary.
Gareth.
It is Gareth.
Yeah.
It is,
Oh,
yeah.
okay.
You're right first time.
You mentioned about preventative medicine as well, like vaccinations. What I'd really like to know is what are the most common reasons for repeat admissions? Is it, when I used to work on the 999 calls, the Friday night, card 17, where people would be falling over all the time, that was a major one. And we implemented a system where, rather than using an emergency ambulance, which roughly it's to about £1,000 an hour, is that about the same now? We invented a team called the Falls team. There was 2 or 3 guys, used to go around in a van, which was much cheaper, and it was very effective. Do you have a similar thing here in Staffordshire? So main question really was, what are the main reasons for repeat attendance?
So I'll take the first part, and I'm happy to say that Staffordshire does have a Falls team. We've got, and I think somebody referenced it earlier. So we have, Jack's mentioned about the ambulance service managing the green calls, but for the amber and red calls, we have something called the acute care at home team, which includes actually 2 occupational therapists who will go and see the patient at their home. If they're clinically safe to stay at home, then those OTs will then do a risk assessment and make sure that they get any adaptations that they need. If they've injured themselves, then the advanced clinical practitioners will then arrange for them to either be treated at home under the care of a consultant or transported to the hospital where we think they might have been injured. We've also got the option now of the X-ray car, so we can actually X-ray people in their own home if they've had a fall to exclude whether they've had a fracture or not. So we're pretty far advanced. In terms of emergency admissions, it's a little bit seasonal, but in terms of the repeat admissions, we probably need to separate out, actually. There are lots of people who attend ED repeatedly who don't get admitted, and those tend to be people with substance issues or with alcohol problems. Those are the most common denominators. But for people who get admitted, the most common issues are chronic conditions like COPD would be probably pretty near the top, people with heart failure, people who are just frail, and people who have got end-of-life conditions. So those are the people, that, you know, the top part of the pyramid of people, what we would call the high-intensity users that go into the hospital. But we have services to cover both of them. So the high-volume users, the people with the alcohol and substance abuse, there's a team of people to support them, including social prescribers, mental health teams, clinicians from the hospital, to try and help them in that pre-hospital space so they can use other services and to also access things like accommodation, support with their addiction issues, and so forth. The high-intensity users is a team which allows us to focus support, including primary care and community teams, to support those patients who are coming into hospital for admissions on a frequent basis. And those are well established. We've been doing that for a number of years, but they become more, I think, more sophisticated over time.
Okay, thank you very much. You mentioned that you're a clinician. Well, what do you mean by that exactly?
I'm a GP. But
oh, Will. Great.
Yeah.
Thank you very much.
Okay, thank you very much for your questions. Councillor Doherty.
Thank you. I just want to go back to a point that you made, Steve, and that was promotion of 111. It's a great service, and there isn't enough awareness around what services they actually provide. As an example, GPs hold a percentage of appointments open in case of emergencies, and if you know, and a lot of people aren't aware of that. You know, that they can call 111 if they can't get an appointment by normal means, and then they can, because I've done it myself, I've called 111 and they've contacted the they've contacted the GP, and then they've contacted me for an appointment. So I think, not a question, but a suggestion that maybe more awareness can be made around what services, 111 actually provide, because a lot of people don't know.
Thank you. That's really helpful feedback. The Think Which Service campaign that we will be running in the winter is explicitly based on Think 111 and Think About Community Pharmacy. So there's two things. But you're right. The 111 can do an awful lot to signpost patients to the right place and the right care. But thank you. We'll make sure that is really explicitly covered in our comms campaign.
Okay, thank you very much for your question. Councillor Luca.
Okay, thank you, Chair, but I believe Councillor Norman did put his hand up before me.
No, that's okay now, so thank you.
Okay, thank you very much. Is there any...
Yep, okay. Again, talking about ambulance crews, staffing and discharge. When an ambulance crew's actually tasked to go and pick a patient up from a ward, a lot of the time we only had 15 minutes to do so, from point of arrival to actually picking them up and having them in the back of the ambulance. And we would get up there and medication hadn't been sorted, or the necessary paperwork hadn't been sorted. So again, what it actually meant was we had to stand there for 15 minutes, and if that 15 minutes come up, then we had to actually get back to discharge, and discharge would then have to reallocate another ambulance to come and actually take over the job that we'd been tasked to do. I mean, which obviously causes backlogs and frustration, and not just for the patient, but also staff morale. I mean, so the point I'm trying to get towards is, through the whole process, I believe last October there was something like 46,000 hours lost of ambulances sitting out of emergency departments waiting for handovers. So there is a lot of work that needs done. Now, you've mentioned that you're in deep talks with all your partners. Can I actually get some type of ballpark figure to what you've actually done to address this? What actually is the goal you're looking at this year to pull that down to, again, percentage-wise? Because you're not going to fix this overnight. I mean, it's basically impossible. I mean, and what are you doing on the wards to make sure that when crews have actually been tasked a job, that the necessary paperwork and medications, so we can actually then take charge of that patient's care, is there, because it's spending money when money doesn't need to be spent if we get it right the first time.
Thank you. Really useful sort of insight and intelligence to work through. So if I address the sort of the lost time in terms of the handovers and the patients that you're collecting, first of all, as we go through. So as part of our improvement programme in that discharge work stream, our integrated discharge hub, so our IDH, have a real focus around sort of core work streams, transport being one of them, and making sure that patients are ready, making sure that patients move through. There's a number of initiatives this year that have been launched, including electronic prescribing within UH&M. So patients now there's no need to get a doctor to come and handwrite a prescription out, for that then to go to pharmacy, for that then to come back as it works its way through. They're using electronic prescribing now. This will be our first winter with it, and what we're hoping to see from that is a much improved prescribing process that stops some of those delays. But in terms of the transport, our IDH team and our IDH director is working really closely with EMED, our NEPS provider, on this issue, and it's a regular daily discussion and touch point as they go through, and we are starting to see some improvements in those areas to pick up that one. In terms of the where are we aiming for in terms of lost hours for ambulance handover for patients coming in, we have agreed, well, we have sight of, and UH&M have worked with NHS England to agree their operational plan for 25-26 that talks about the trajectory that they are getting towards in terms of the numbers and the percentages. I'm going to be honest, there is a number of hospital operational plans and metrics that pass through my brain. I can't recall them off the top of my head for each of them, and I've dropped off your internet, so I can't get onto loop. But what we can do is take that away and bring that back to give you an idea of where we are, where we've got to so far this year in terms of our plan and our trajectory, and what the plan is for UH&M colleagues for the winter coming.
Yeah. Could I just add to that, that one thing I do have to emphasise is just how actually hard the NHS staff, actually which are on the wards and in the departments, do actually work. But the issue is obviously when all these backlogs are being basically causing a damn effect, it means that department that's waiting to send a patient up to the ward can't, because they can't release that bed that's on the ward because there's nowhere for that person to go to. And there has been situations where you've had people, just so you can free the bed, sat in corridors in chairs for, 10 to 12 hours waiting. And that's actually, under no circumstances is justifiable. So again, when you're writing this report, are you actually making sure that you're not just going to actually do the let's push them out and forget about them?
I think it comes back to the comment that I made with one of colleagues over this side of the room, I can't remember who, sorry, previously, around the delays. It's a whole hospital pathway flow issue that needs to be addressed. It's not specifically A&E where they're on trolleys, it's not specifically any department. So that is a real focus of not only us as a system, but particularly of UH&M as a provider of the acute, which is where we have those patients holding on corridors, etc., the most as we go through. So this isn't a case of push them and they're gone. We are constantly managing, assessing, and that's part of the team that sit under Gareth and myself is the System Coordination Centre. So we have a team of sort of commanders that are pushing and monitoring that on a daily basis, 7 days a week. And we're not only looking at it from a numbers perspective, but Steve is a clinician working with our quality colleagues, are regularly receiving data, but also going out into A&E, going out onto the wards, checking that patient experience, of having that lived experienced piece as we go through. So yeah, it's not a case of sort of push them out and it's on paper and it's done. It is something that's monitored and felt by the team on a regular and daily basis.
Okay, thank you for that, and thank you for your honest answer.
Okay, thank you. Councillor Broom.
Great. Going on from what Councillor Lucas said, you mentioned in your report about 7-day working. I think you just mentioned it there. Can you be specific about what departments aren't 7-day working? For instance, our theatres, the high end, are they being utilised as much as they could be?
So do I have a definitive list of what I can say is and isn't 7-day working that I can share now? No. What I can say to you is all services and all departments have appropriate processes in place to be 7-day working. So if that isn't physically a clinic of this speciality running on a Sunday morning, then no. However, what there is the ability to get an appropriate clinician who's on call to deal with that speciality. So does 7-day working happen? It does, and it's in place. And taking your point about theatres, yes, they're operating. Is there more that can be done around efficiency and trying to get more out of those programmes? agree with you, and that's part of the elective improvement programme. So there's the non-elective improvement programme and there's the elective improvement programme that is looking around things like theatre utilisation, outpatient appointments as we go through. But there is 7-day working. It's just about the way in which that happens. Do we need to do more of it on site? Do we need to do something differently? And that's the part that we're addressing through the urgent and emergency care pathways. And we did last year, and we will be a focus this year and for future years.
Do you have a goal, a timeline goal for achieving 7-day working? Do you have a plan?
Because we're already doing 7-day working, there isn't sort of a goal of when we're going to achieve it. It's a constant evolution and improvement programme. So what I wouldn't want to say is, you know, there's written down on a piece of paper that by August of next year, for example, we're going to have everything 7-day working, because something new will come, pathways change, clinical guidance changes on a regular basis. That means that needs to adjust. So quite often, the general services that cover the main population, so acute medicine, general surgery, things like that, they are all there and they are all operating. It tends to be more of those specialised specialities and functions that have an escalation access route, rather than truly there's somebody sat there 24 hours a day, 7 days a week there. They are there, but you may not physically be in the hospital at that moment in time.
Okay, thank you very much. Councillor Luca.
Okay, again, thank you, Chair. One of the things, obviously, again, when it comes to you putting this plan together for the coming year, is out-of-area beds. Because obviously, it does play a major part. If you can't get the people into that hospital that this plan's working for, you then have to look at other spaces. Now, this is going back to one of the reports that did come last year, where they allocated for 5 beds, but they actually ended up using 20 outer area beds. That was obviously like a 75% shortfall on what was actually needed to what was actually put into the plan. So my question is going to be, learning from past experiences and past plans, what are you actually putting in the plan to make sure that something like that, because that's a major oversight, 75%, is not going to happen again?
In the context that you framed it and sort of the numbers that you've said through there, I think that was around out-of-area mental health placements and beds, rather than sort of core medicine bed base, as we would call it, for the vast majority of our patients as we go through. There is a programme of work led by our mental health portfolio colleagues that focuses around utilisation of out-of-area beds. I don't profess to be the knowledge and font of all knowledge in around those areas. What I can say is our mental health providers have been through a programme of actual essential maintenance work that's meant that we've actually had to have less beds in our area whilst that maintenance work's been taking place. And that programme is still ongoing, it's not concluded, but what we're now starting to see is some of that capacity coming back into place. So I think that won't be the only reason, but that's been one of the core drivers around those pieces of work. Certain mental health beds, and they're categorised into different tiers, aren't actually managed locally. They're now managed on a regional basis, because they are those really high acuity specialist placements that you may have 1 or 2 patients a month or every couple of months that need those through. So they actually happen on a regional and a national basis to go through. So sometimes patients do unfortunately have to travel for those specialised knowledge and services. It's not ideal and it's not where we would want to be. However, because their speciality is so special, is so highly specialised, I suppose is the better word to use, sorry, then those patients do have to move out. But I think that's the sort of driver behind that, is around some of those maintenance programmes and things. But for assurance, there is a dedicated mental health programme that's overseen by colleagues.
It's just the reason why I bring this up, because obviously this is a plan, and it's not just for the clinical beds. This plan is to cover everything, because if you're not going to plan for something, how are you going to have a policy driving forward for your staff. I mean, it's going to be a lot of headless chickens running around if that was the case.
Yeah, and sorry if it didn't come across that way, you're right, the plan is, and that's one of the pillars, so mental health is one of the 13 pillars that sits through, and we do have those conversations. When I'm talking about it's managed by wider colleagues, what I'm talking about is they hold the detail of that 5 and 20 and how we got to that position go through. I can't comment on, it's not the area of knowledge that I've got in that close enough detail to be able to give you that answer. But in terms of the plan, you are right, the plan covers everything, and that's through the pillared approach that we make sure that we get that visibility and oversight at an appropriate level of knowledge that we need to support the different parts of the patient pathway.
Okay, thank you very much for your question. Does anyone else have any questions? No, I've got a few for myself. I do apologise. I know it's rolling on a little bit. Right, okay, so what reduction in avoidable hospital admissions do you expect this winter compared to 25-26, and how are you going to measure this?
Sorry, I was just writing that one down. So in terms of our avoidable admissions as we go through, we are at the point at the moment of finalising all of our schemes. So we haven't finalised what percentage and what metrics we anticipate against each of those. That detail would be in our 26-27 plan that we'll bring back to the committee with more detail as we move forward. However, admission avoidance and work with our integrated care coordination centre and that pre-hospital work stream is a key focus as we go through of the plan, and is actually one of the pillars in its own right as we move forward. So I can't give you the detail on the numbers and the percentage that we've agreed for this coming year at this stage, but we can ensure that's included in the plan for 26-27 when it comes forward to the committee.
Okay, thank you very much for your answer. So you noticed that, you said earlier that there's a flow issue. So what I want to know is what caused the biggest discharge delays last winter, and what has been done to resolve those issues?
So in terms of the discharge delays as we go through, there are varying different causes of our discharge delays, some of which can be transport, some of which can be medication related, some of which can be identifying appropriate packages of care for patients as we go through. All of our actions that we've taken are wrapped up into our integrated discharge hub improvement plan. So in terms of some of the changes, we've talked about the 7-day working. I've mentioned around the implementation of the electronic prescribing to reduce some of those resources through there. There are a number of collaboratives that have been introduced within the integrated discharge team, particularly one around therapies and the various different therapists that work within the hospital. So now they're able to be supported in the patient's journey much quicker, so then they now have a direct link into the discharge team, whereas before therapists sat in one team there. They're not amalgamated, but they've got a pathway and a process to work collaboratively to address those. So those are the sort of programmes and changes that have been made as we've gone through winter. Where are we in terms of moving forward? It comes back to the point that we raised before. It's not about doing anything new. The focus will be about doing what we've started to do and doing it better and taking that forward. So I think what it'd be useful is when we bring back the plan and discussion is to give you a little bit more detail in the overview of each of the work streams and what's in them and what's in each of those work streams as we go forward to give you that assurance.
So you said about bringing that forward to this winter. So what or which measures will demonstrate the patients leaving hospital sooner will be sooner when medically fit?
So we have measures agreed around average length of stay, that we'll be looking for a reduction in average length of stay. We have a particular measure around discharge delays that measures the number of bed days or percentage of bed days from when the patient is declared medically fit to when they vacate the bed. So that's monitored through our UEC board, but also through the Joint Commissioning Board with the local authority, because that's supported by a number of schemes, including the funded through the Better Care Fund. So they are the two metrics that are the key ones that we will be looking at to assess the sort of level of achievement and improvement that's been seen.
And that will be brought forward when you come with the report, will it?
So the Better Care Fund has already been, I understand it was approved by a joint commissioning board. So I would assume that it's come to this committee already. That's a joint piece of work between the local authority and the ICB. I don't know where that sits on your work programme, whether it's planned to come forward, but that includes all of the things that we're doing around discharge delays jointly between local authorities and the NHS. Right,
okay. Okay, yeah.
Chair, sorry to intervene. I'd just like to give apologies that Steve's had to leave to go and attend to a clinical commitment. Thank you.
I'm just going through now. So I have a few recommendations for you, but what I'd like to know is which outcome measures will be included in the new performance dashboard, and will this committee receive those measures throughout the winter rather than only after the winter is finished, and when will the committee receive the performance dashboard so we can monitor whether these improvements are actually being delivered? So what I'm asking there is there a possibility that while you are going through the winter, is there a possibility that we can actually monitor what's happening to make sure that those things that you want to deliver are actually being delivered at that point, rather than coming afterwards like now, which is a long time after, to be able to see that things are being given to our Staffordshire residents, and us being able to, as a committee, being able to see that.
In principle, absolutely. If I may suggest, we do updates to our ICB board on a monthly basis. It would, in governance terms, we would prefer to give you the material that the board has also received and noted in any actions that they come from that. So perhaps if we share, because I'm not expecting the committee to search the internet for it yourselves. I mean, we'll provide that, and we could do that on a monthly basis after the board has seen and approved it, if that would work.
I do really appreciate that, and I understand we're not trying to micromanage the ICB in any means. We're just looking for assurances that those things are being delivered. That's all. Okay. Just in case you thought we were trying to sort of judge everything that's going on. Okay, no, Councillor Luke.
I understand, Chair. I mean, there's a balance as ever, and Jack alluded to this earlier, to give you timely information that isn't out of date by the time you get to read it. So we'll discuss that internally, and we'll attend to it as I described.
Thank you very much. I really appreciate it. Councillor Luca.
Just going forward, because obviously we've talked about finances and budgets getting tighter, and obviously delivering services for the Staffordshire people. So would it be possible to have some data on the issue with hospital tourism, which is happening within our area? For the councillors that don't know what hospital tourism is, it's when people from all over the world come and actually use our services, and then when it comes to actually paying, they disappear out the country again, leaving quite a substantial bill behind them. And obviously that comes out of our fund, which has been allocated to provide for the Staffordshire people.
Okay, I do understand your concerns in that, and that is a very real concern, especially for the taxpayer. However, I don't think that's relevant to the winter plan. However, I'm sure they wouldn't mind if we forwarded the question to yourselves and you could sort of maybe give us an answer, if that's okay.
I recognise exactly what you're asking for and why, Councillor. I'm not sure we hold that level of detail at the ICB level. I mean, the provider trusts would probably have that, and if UHM come to appear in front of the committee, that may be one to focus in their direction, if that would be okay.
Thank you very much, and thank you, Chair. I just wanted to make the point, because obviously it does come out of the finances for the people from Staffordshire.
Okay, thank you very much. Okay, so we do have some recommendations. I'd just like to go over those again. So we do recommend that the ICB considers establishing measurable targets to determine if the work to improve staff morale and reduce sickness in emergency departments has been affected. We'd also like to recommend the ICB considered a communications campaign to highlight the public of alternative positions of care available, and also, have you got those ones written down? Yeah. Okay, also to recommend that the ICB consider implementing a permanent discharge ambulance to make discharges more efficient. I think that is then everything. Does anyone else have any more questions, anything? Okay, thank you very much for coming and giving your report. We very much appreciate it. Thank you very much. Okay, next on the agenda is District and Borough Health and Scrutiny activity. So is there any of the districts or boroughs that would like to come forward with some of their activities? Councillor Norman.
Yes, on the 14th of July, in fact, we had a full council meeting which went on till 10:35 at night. It was a very important meeting, and it wasn't a scrutiny meeting, it was full council. And I think as the officer was at that, as well as our scrutiny, serving our scrutiny committees, he's probably too exhausted to realise and put in the wrong date there. Our next meeting, in fact, is tomorrow, which was a bit annoying because it's hard for me to report so quickly from today for the meeting tomorrow. But we did in fact meet on the 16th of June. There wasn't any health issues except that we discussed the local plan at great length. And we've heard about planning earlier today, so we have got a health scrutiny task group on the health scrutiny, on the our scrutiny committee. So I'll be asking the chair of that task group to contact Councillor Doherty to find out about the issue of GPs in Birmingham, because we've got a number of planning applications coming into Burntwood in my area, and every one, the ICB says no problem, there isn't any need for any extra health services, or they can ask for that under the rules. So it isn't a health issue, and I'll be asking Councillor Doherty, who's our representative at Lichfield District, to respond to that. Thank you.
Do you have a response?
Not actually today, but I can look further into that for you, and then I'll contact you as soon as I find out any more information.
Okay, thank you very much. Councillor Swindlehurst.
Thank you, Chair. And obviously you'll know that this is my second meeting. We've changed chair of the Health and Wellbeing Group at SMDC, and thinking forward in terms of having a legacy plan and what we leave behind when we're no longer here, we've sort of changed our focus really in terms of using the NHS 10-year plan and looking at the responsibilities of a district council in terms of wellbeing. So we're taking our focus as being representing our community, obviously, specifically Staffordshire Moorlands at the moment, influencing formal health scrutiny such as this, partnership working, and scrutiny of and work on determinants of ill health. And what we've used from the population of the data on the population of the Moorlands is an ageing population, long-term conditions, for example diabetes, which is rife in the Moorlands, rural health challenges, which I mentioned before, health inequalities, which, for example, my ward is the poorest in the Moorlands, it's the most deprived in the Moorlands, with its own particular needs, and mental health and well-being. And what we're trying to do is instead of bringing things to this committee, so say, for example, failures of something, what we want to try and do is look at, for example, if we look at diabetes, there are across areas screening programs that will go out into the community. So it's looking from our perspective where they can go out, how we can access that service. So sort of using this relationship to see actual benefits Does that make sense? So sort of that we're doing things that have an action and have something that the community can see and perceive that we're actually doing something rather than complaining. That's the and we don't ever mention potholes ever anywhere. So that's it.
Thank you very much. I would actually like to mention something. Maybe I should have said this previously to bringing in the districts and boroughs. But in my sort of scrutinisation, I'm sure you all on this committee noticed it as well, there was a lot of mention of funding, maybe shifting into the 5 shifts. There could be a risk of lack of funding, that vacancies are frozen due to funding. They have to have more staff, could possibly use more funding. You know, ambulance response times, capacity with more beds, capacity of more services would need funding. I was thinking and have gone through this and thought about this greatly, and I would like to contact the gentlemen that were here and see if they would like to give us some information on where funding would be better needed, and then going forth to our government and lobbying them for more funding and ensuring that funding for our hospitals is there so that we can still deliver to our Staffordshire residents, if that's something that everyone else wanted to do. So that being said, I'd like to have a show of hands on who would like to...
I didn't quite catch who you're going to ask and what was it under? Was it under the work programme or under the council? I didn't quite catch what you said, actually, Chair, sorry.
What can you
quite catch what you said. You're going to ask someone about funding. I didn't hear the who was.
The government.
And are you raising this with... We're going to write to the government?
Yes.
Oh, good luck, yeah, okay.
So, I would like to have a show of hands if everyone would like to proceed with this and see exactly where we can go. Yes, of course.
Open-ended in terms of what's the level of money, what's the specific projects that you're looking to have funded.
Yeah.
I mean, it would be better if we had a bit more detail.
That's why I was going to communicate with the gentlemen that were here and find out exactly what level of funding would be needed if we were to go forward with that. What services would need more funding, whether it would be with more staff, frontline staff, more ambulance care, maybe opening up more services in other hospitals to remove the pressures that UH&M Stoke seem to be under. And, you know, if we could probably go forward with anything like that. I mean, Councillor Greatrex, would you like?
It's open-ended. I mean, you know, we're talking about 3 million, 30 million, 300 million. It's how many hospitals, how many rooms, how many projects? It just seems a bit like you've got a good idea, but no detail behind it.
That's why I wanted to obviously have further communications with the gentleman that came from the hospitals. Councillor Luca.
Yeah, just 2 points. Obviously, as you've already stated, Chair, you would actually be talking to the gentlemen that do have this knowledge and can give clear and precise directions and what they actually do need service-wise and financial-wise. So, I mean, I'm going to say yes to this. But one concern I do have when it comes to the districts and the boroughs, I mean, I welcome everybody that actually takes the time from the district and boroughs to show up. But what are we going to do about the districts and boroughs where their representatives never show up? Because how can we actually truly get them to represent their people? Bringing in their concerns to county. Because, and the reason why I mention that is we had one person that's been on this committee or allocated to this committee, and they've attended once in a year. I mean, sorry, but that's just not good enough when it comes to like, serving the people of Staffordshire. We need to make sure that if you're going to take these outside body positions, they attend the meetings. So what can we do to address that, please?
Are you talking about the districts and boroughs, or are you talking about officers? Yes, I am greatly disappointed myself that many of the, or a few of the districts and boroughs that should be here attend very little meetings, if any at all. I am taking that forward and sending out an email to specific councillors. That is in the my own agenda in the background to do, and that is something that I am doing. In regards to what we were just talking about, I would like to go forward and discuss with the relevant officers that have obviously all the information, like Councillor Lucas stated, if there are any funding concerns, and if they would want us to go forward and lobby the government for more funding, because at the end of the day, I believe that we are underfunded as Staffordshire as a whole. I've heard many times that Staffordshire is one of the lesser funded areas, and to be honest, I think it's something that needs to be, you know, done, and we need to be able to lobby the government as appropriate to what we're asking for. Now, obviously, I need to find out exactly what that is from the relevant officers, and then if they identify where they could do with better funding, then I'll bring that forward to yourselves, and then we can go forward with that. Okay, sorry, there's several hands are up now. Councillor Mandrick.
At this point in time, although it is open-ended, you know, you said you were going to go and speak to the relevant bodies. I think it's brilliant, personally. It's better than just sitting here dormant. At least we're trying to give back to the people of Staffordshire, so I fully support it.
Councillor Broom.
Thank you, Chair. I don't think, I mean, as long as, I would imagine that we're all behind you on having more funding. I think having a chat, which you can do with the officers in question, and finding out specifically maybe 1, 2 or 3 items, and then come back and we'll back you on a specific plan. I think maybe that's a good framework to have. But great idea, thank you.
Councillor Doherty.
Yeah, I'm in agreement, and I agree with what Councillor Bream said.
Councillor Luca.
Yeah, again, I completely hope that everybody takes us on board. It is better to be proactive than reactive.
Councillor Swindlehurst.
Thank you. I think, having read around it a lot, we can tell you the answer now. Of course the NHS is underfunded. It has been for about 30 years. Every department's struggling, like we all are. I mean, I think personally, I'd prefer to know what the question was before I vote for it, because the response will just be wishy-washy. It'll say, of course we're underfunded, everywhere is. And I'd quite like the consultation, like Councillor Broom says, to take place first and then come back to us to say this is a question we want to ask.
That's excellent. So from what I've gathered, if we get the evidence together, talk to the relevant officers, see if they do want the funding, to see where they need the funding, how much funding they need, and then to bring that forward to the committee for review, and then see if that's something we want to take forward to the government. Yes? Yeah. That's excellent. Thank you. Sorry. So next on the agenda is the work programme. Would you like to take over, Zach?
Good afternoon, Chair. Yeah, just for the committee to approve the work programme. I don't believe there's been an update since the last time, so it's just if anyone had anything else to add to it. Thank you, Chair.
Yeah, I think Zach already knows my two. I'm a bit concerned that there isn't any reference anyway, and we've got a few issues in Staffordshire Moorlands about the protocols around health visiting. We've got some people that have had multiple births that have had not the statutory amount of visits. They should have 5, they're getting 3. So that's one area of concern. And another big area of concern for me at the moment is we've concentrated for over an hour on cold, but we haven't concentrated on heat. And there's thousands more people dying over the last week related to heat and heat stroke, etc. And it's probably too late now anyway, because we're already in the process. But I wonder whether we could disseminate something to councillors to disseminate to their communities about just things that you do related to heat, you know, what the emergency things are, who do you contact, how to keep yourself safe. And I'm sure they'll be aware through public health. So it's not necessarily a work programme issue like the health visiting one, but it could be in the future, obviously. But I just wonder whether Zach's got any information about what we could access now so that we can pass it out, even if it's just related to comms, for example. Thank you.
Okay, what I can do is I can take that forward to the ICB. Okay, thank you. Councillor Doherty.
Yeah, I'd like to mention rural transport for NHS services and how we can improve on those, because Lichfield Rural East is my division, and I've had a lot of people contact me, especially as is it Councillor Swindlehurst? Yeah, Swindlehurst raised with the conditions that we've been having over the last couple of weeks, and they've not been able to get the transport that they need, elderly folk specifically. I mean, maybe not necessarily brought up on the work programme, but maybe we could have a look at, you know, having a working group perhaps to have a look into that.
Yeah, it's right if you email that forward to me.
Yeah.
Okay, that's fine. Thank you. Has anyone else got any comments or suggestions? Oh. No? Okay, so now I say this meeting is closed. I can't see the time because my laptop has suddenly decided to restart and update. At 1:20. Thank you very much for everyone for coming.